Post-banquet night, we are running a bit late, but we'll try to make up. Our speaker for today's session is Dr. Abhishek Jairaj, and he'll be talking upon a topic which is of very much relevance in today's world, that is sleep apnea. To chair the session, I request Dr. G.R. Ashok sir to please come up on the dais. Sonjit. ডাকলাম খেয়াল করিস নি।
Good morning, everybody. There seems to be more chairs than people, but that's expected after a banquet, probably. Dr. Abhishek Jairaj is our speaker this morning, and he is a specialist in prosthodontics and oral implantology with more than 15 years of experience. He graduated from SDM Dental College, Dharwad, and completed his post-graduation from Oxford Dental College, Bengaluru. He has extensive experience in academics as a faculty in India and Malaysia, and also has many years of experience working as a consultant in corporate dental clinics and private practice. With particular interest in CAD/CAM technology and dental laboratory work, he is also a technical specialist with Dentcare Dental Lab, Kerala. Currently, he maintains his private practice in Bengaluru and has interest very keen in wildlife conservation and environmental protection. So the stage belongs to now Dr. Abhishek Jairaj.
Thank you so much, sir. So very warm good morning to all esteemed members. And first of all, to begin, I would like to thank the organizers of this beautiful conference, the IDA West Bengal State Branch and the IDA North 24 Parganas State Branch. I know very well how difficult it is to organize conferences and how much work it takes. So I really must appreciate all of you. And also I must appreciate the beautiful venue that you have chosen. So I stayed here yesterday and today morning took a whole walk around the campus. I like to call it as campus because it was so big, especially the private villas towards the backside, real old money people, exactly the kind of patients that many dentists look for. So this is a great platform, and I am very, very happy to see all of you. So it doesn't matter to me that the hall is not full, but you are the exact people whom I want in this hall for this particular presentation. And I hope we'll get more as the day moves on. Right, so we'll start with the presentation now. So just a little disclaimer. I'm a prosthodontist. Okay? I'm a specialist in prosthodontics and implantology as well, as we like to describe it. And also, as sir has mentioned, I'm a pure private practitioner, but I also serve as an advisor with arguably one of the biggest laboratories in the country and the world, that is the Dentcare Dental Lab. So this collaboration is very, very essential with the industry as well. And also the two logos, as I like to put this as the slide, because I noticed that both the logos of the IDA and our the company, they are very much color coordinated. So this is like one of the things which we feel bonds the lab and the IDA together. Also, since you're here, if you haven't visited, I would like to invite all of you to Kerala, that is in Muvattupuzha, exactly 1 hour from Kochi Airport. So if you come there, please do feel free to visit the laboratory. So we'll be very happy to have you. So you can do like almost like a day-long tour. So if you just meet with our executives and just tell them, they'll arrange it for you. So if you just come down to Kochi, do come over, keep half a day aside and visit the lab. It will be an eye-opening experience for you, because as dentists, we think of laboratories as little dingy places, or our prosto labs in the colleges where a lot of plaster stone flying around. This is very, very different. This is like a dental college actually. So different departments, huge departments and all that. So very, very nice place to visit. So please do come over. The invitation is for you. So we'll start with the topic now. I would like to start with this particular quotation, which I really like. So when we enjoy challenges and we start learning, we have to learn to tolerate ambiguity. Ambiguity. In the end, there are no certain answers. So I'm sure many of the experienced dentists will agree with me that more you study a subject, more you delve deeper and deeper into a subject, the subject starts becoming ambiguous. As in, a question which has many answers, all of them seemingly correct. Nothing is really wrong. It's okay, this is more correct, less correct, least correct, something like that. So as we delve deeper and deeper, as we become specialists, super specialists, sometimes instead of things becoming more and more crystal clear, they become more and more ambiguous. As in, a question with many correct answers. So this topic is a little bit like that. So we have to keep a very open mind and go ahead with that. So since I'm a private practitioner, so most of the work that we do in private practice is essentially general dentistry work. That is our crown and bridge works, root canals, periodontal treatments, you know the thing, orthodontics, everything to do with general dentistry. So private practitioner is always in a battle. It's like a battlefield with many dentists in that area. So we want to be one up over the person in that area. So we have to have knowledge and skills nowadays which can take you one step further than what you already are, which I'm very sure all of you are very experienced dental practitioners. So general dentistry is no problem for you. General dental procedures are absolutely okay with you. But when you start doing something new, the question arises, should I do it or not? Or is it correct for me to do it or not? So we have to get through that and then get into this particular aspect of dentistry. Okay? So clinical expertise, communication coordination skills, and of course, the kind of marketing acumen, fortunately or unfortunately in 2025, marketing is very, very important for a dentist. So dentist has to be good with marketing as well. You have to market your own practice. Okay, so here's a question. Now, if you look at this slide, you will see that this is a question, right? It's a question. In most of the different cultures, languages, this question arises. So if you meet someone, especially in the mornings, like how you all met today morning, you ask each other some questions like, how are you? What's happening? How was the previous day or whatever? But if you meet someone who is over the age of 40 or even 30 or 50s or 60s or for that matter, there is one question which always arises. Can anybody understand any of these things written here? Yes, which language did you understand? Oh, Gujarati. Okay, great. So that was Gujarati, and we have German, we have Tamil, we have even Telugu, and all those Italian and Chinese and all that, okay? So, now I'm sure all of you will understand what is written here. Sir has already vetted it in the morning, so I'm very confident. So basically the question is, how was your sleep? How did you sleep? Did you sleep well, etc., etc. So this is one of the most common questions asked to a senior person. By senior, I mean 30 years and above, not 60 years and above. Anybody who's 30, 35 can be called as a mature or a senior person, okay? So keeping this in mind, there is one problem that many people suffer from. It's like a silent problem, but nowadays it's coming out into the open a lot. Okay? That is the problem of obstructive sleep apnea. So we have made this presentation to suit the general dentist, as in even a dentist who has started his practice or who is very, very new, or even somebody who's doing post-graduation or something like that. So we've kept it in such a way that those dentists can also start incorporating this particular aspect of dentistry into their practices. So we call it as expanding general dentistry. So the regular general dentistry is being expanded into other fields, which you all know. And there are some fields in which there are conflicts, clashes between the dental and the medical fraternities also. Okay? This is not that kind of a field. Obstructive sleep apnea has always been associated with dentists. It's not exactly a ENT field or anything. It has been there. Of course, as and when you go more and more advanced, it goes towards the medical practitioners. But this is something that each and every dentist can incorporate into their practice as well. Okay, so there's three terms that we want everyone to understand. That is apnea, all right? Apnea basically meaning stoppage of breathing complete. So if you hold your breath, let's say if you just hold your breath, you are in apnea, complete stopping. Then you have the hypopnea, That is the stoppage of breathing, but partial stoppage, not complete, partial. For example, somebody who's snoring, okay, that can be called as a hypoapnea. That's not apnea, that is hypoapnea. So if you see someone snoring, that can be described as the person is in hypoapnea. Which brings us to the term of sleep apnea. Of course, when you are awake, you will not snore. You are going to snore only when you're sleeping, okay? Because you're unconscious or semi-conscious state of mind. So if you understand just these three basic terms, you can also understand the next term, that is obstructive sleep apnea. Obstructive, of course, that means something is stopping you from breathing. Okay, what is that something? We need to find out, and then we need to address it. Okay? So once we get through this basic terms, then we come into the types of these things. So in this, as dental surgeons, as general dentists, we don't need to delve or dive too much deep into the central aspect of it. So if you look at this, we have central sleep, we have obstructive sleep apnea, and then you have a mixed region, the ambiguous region, that is the mixed, which nobody really knows what exactly it is. So this is something which even medical professionals sometimes they struggle to diagnose, or they struggle to treat as such. It's a very vague sort of a description. So in very simple terms, if you say central, means the brain is just telling you not to breathe. Okay? Obviously, when you are awake, the brain cannot tell you not to breathe. Only when you are sleeping, the brain gives the signals. Obstructive means the brain is telling you to breathe, but you cannot breathe because there is some sort of an obstruction, either in your nose, in your throat, or any of the airways. So that is the obstructive. And mixed is a complex form of this particular thing. Now, if you get a patient, of course, on your dental chair, first thing, you're not going to look at this aspect only. You're just going to look at the dental aspect. You're going to do your whatever OPD that you do. But from now on, we would like you to just add a few extra questions to the patient. That is about the sleeping of the patient. Are you sleeping well, or do you have issues? And there are some patients whom you can particularly target with these questions. Not everyone. This question cannot be really asked to every patient. But if you look at a kind of a patient, there are some particular types of patients for whom you can ask these questions. So we will be dealing more towards the obstructive type of sleep. Central, first of all, the diagnosis is very, very difficult, even for the medical professionals. And you need the help of a sleep lab or a medical professional to go into this as well. Okay? So as dentists, we can definitely have a very good idea whether the patient has an obstructive sleep apnea or not. So when we say obstruction, there are two ways that air can enter. That is either through your nose or either through your mouth. So one of these two airways, there will be an obstruction. Okay, either the tongue is falling back too much, or either the walls of the pharynx are collapsing, or either there is an obstruction in the nose, deviated nasal septum, or anything like that. So that is an obstructive type. So how will you tell if the patient is sitting on the dental chair? How can you tell? So there are certain patients. We'll take a look at the types of patients as well. There are certain patients. So suppose if the patient has a huge neck, okay, or if you keep a suction tip in the mouth of the patient starts gargling. Have you seen that? Some patients, they start gargling when you keep the suction tip. Okay. And some patients visibly who are extremely obese and who sit on the dental chair and they breathe heavy. So such patients, you can very well go through a questionnaire. You can give them a questionnaire and you can counsel them about this sleep thing, or whether they are having any kind of an obstruction while sleeping. Most of them, with proper counseling, they will give you a yes answer, and then you can proceed with such patients. So what are the symptoms? Of course, the number one symptom, the most widely known symptom, of course, is snoring. Snoring is something which anybody can easily observe, and if you don't know, somebody else will tell you that you are snoring. That is for sure. Okay? Somebody will tell you, okay, either your friend or your spouse or anybody, they will tell you that you snore. Witnessed apneas, as in somebody has seen you snoring, gasping for breath when you're sleeping. They see you and they tell you, boss, you need to do something about this. Nocturnal choking or gasping, you wake up in the night gasping. You realize that there is a problem with your breathing. Okay? Insomnia, cannot get sleep. Dry mouth, daytime sleepiness, all these things. So these cannot be confused with, some people they confuse it. They think that they're very overworked or they're very tired or something like that. They start consuming more tea, coffee, and smoking and all those sort of things. And they try to mask it. But it doesn't really go away. It just either stays the same or it just keeps getting worse. Okay? So now you have a vague idea. So if you get a patient on your chair, and the patient you feel that this patient might have this issue, you can screen them for this. So how can you screen them for this? You can keep maybe 2 simple questionnaires in your clinics. Very simple questionnaires. The first one being the sleepiness scale, the Epworth. It's a very simple question, a very small questionnaire. If you just give it to anyone, within 2 or 3 minutes, they can fill it and give it to you. So this is essentially for seeing the alertness of a person. How alert is the person? Okay. So what is your score? Okay, 0, 1, 2, 3. So patient will fill it. So if you see the situations, sitting and reading, watching TV, sitting inactive, being a passenger in a car. Okay. So these are scenarios which patients go through in their day-to-day times. Okay. In fact, I feel even in the dental conferences, we can keep this scale, especially for the afternoon presentations. Okay. So you can keep this and you can actually do a study. Okay. This is idea for the younger students. Many studies can be done on this. There's not much happening in this field, so anybody can do it. So this particular questionnaire will give you a score. That is the score. So if the score is 0 to 6, I mean, you can say that the patient is getting sufficient sleep. So you're just believing the patient. So most of the time, you assume that the patient is telling you the truth. Okay, so you don't anticipate things because they are sitting with the doctor. Most of the times, they will give you the correct answers. But if it goes above 7 to 9 or 10 or above, that is when you can suspect that this patient can go in for a sleep study. So for this, the dentist has to talk to a patient a lot. This is not for very busy practitioners who don't have times to spend with the patients that much. Okay, this is for doctors who like to talk to their patients. You have to sit with the patient. There are some doctors, right, who like to sit, talk to the patients, explain a lot of things to patients. So when we brought this into the dentists, general dentists, so many of them were like, we don't really have time to do this. Okay, so you need to make some time for some patients, okay, depending on the kind of practice that you have, to make them fill these questionnaires. Next, and even more simple and more conclusive is known as the stop-bang questionnaire, okay, S-T-O-P-B-A-N-G. So this was developed by anesthesiologists, okay, in the 90s. Before giving anesthesia, they used to give this questionnaire, and slowly it was adapted into the sleep field as well. Stop-bang. So S just means, these are questions, you can see it. S means snoring. So the question is, do you snore? The patient is just going to circle yes or no, that's all. T is, do you feel tired? Tired. O means, has anybody observed you? Has somebody else told you that you snore or you gasp in your sleep? P means, do you have high blood pressure? So wherever you are ticking yes or circling yes, you are giving yourself 1. Or wherever you are circling no, you are giving yourself 0. Okay? So the dentist can calculate the score based on this particular questionnaire. Then comes the bang, B-A-N-G, BMI more than 35. So BMI can be calculated easily, okay? Weight and height, you just type it and you'll get a rough idea of the BMI. Age, unfortunately, anybody who's over 50 years automatically will get a 1 point. Okay? Automatically gets 1 point. Neck circumference, if it's more than 17 inches, you automatically get 1 point. And unfortunately for males always get 1 point. So males can never be 0 point, 0. Male will always have at least 1 point. Okay? So based on this very simple questionnaire, you can have a very good idea whether this patient needs to go in for a sleep study or not. And then you start talking to them and you evaluate the patient. Once if you feel that the patient can afford to go for this treatment, you can push them, you can counsel them to go for it, and then you can treat them for that as well. What do you do if you get a good score? Good means a high score for both these things. Next step is that you shouldn't diagnose it yourself. Okay? Dental surgeons, I mean, we can do trial and error, but it will never be a conclusive answer. So you have to send them to a sleep clinic or a sleep professional. So there in major cities, in most of the cities, you have sleep clinics nowadays. So you have to send them there, you have to refer them, and you have to make sure that they come back. Okay? It should not be that you refer them and they just go away and they don't come back. So you have to have a collaboration with somebody who knows about sleep medicine, a medical professional or a sleep lab in your city. So if you have a collaboration, definitely the patient will come back to you for the appliance. Otherwise, there are many times where the patient goes and never comes back to the dentist. So you want to avoid that, right? Next step will be to send them for the sleep study, of course. So this is like some patients, they just come back saying that, why did you send me there? Okay. So if you look at the picture, you can understand. So this is what they're going to do. They're going to apply all these sensors on the patient, and then they're going to ask the patient to sleep. So good luck sleeping with all these things on your body, and that too in a place which is not even your home. Okay. So one thing which I have noticed, and some dentists have told, that when they send the patients to the sleep lab, actually, the patients, they come back saying that, okay, we went there, we tried, but we couldn't actually sleep. Okay. That is one of the concerns. So you will have to have a pretty professional kind of a sleep lab for the patients to get a correct diagnosis. So once you send them there, and once they check the blood oxygen levels when they're sleeping, etc., the number of apneas, hypoapneas, okay? So this whole thing is the PSG or the polysomnography or the sleep study. So when they count the number of episodes that the patient had, 5 to 15, divided by the number of hours of sleep. So if the patient has slept for 6 hours and he has had, let's say, 50 or 60 episodes, so that will be divided and you'll get a score, which is mild, moderate, or severe. So once you get this score, it will be confirmed. If the patient is in the moderate or severe level, it is 100% confirmed that patient has sleep apnea. Not obstructive sleep apnea, patient has sleep apnea, okay? It is not obstructive. So you still don't know whether it's obstructive sleep apnea or sleep apnea. Then, based on the advice of the sleep lab, based on the clinical examination, then comes the diagnosis of whether it's obstructive or a central sleep apnea. Mostly it will be obstructive only. Central sleep apneas are thankfully very, very rare. So now we have come to a level where we can have a brief understanding of this particular thing and a very simple understanding by 2 questionnaires and screening of the patient, that this patient can probably go for a treatment. Now when we come to treatment, there are 3 types of treatments. One being the most accepted one, that is the CPAP, okay? The machine, you must have seen the machines, the CPAP machines, which the patient has to wear and sleep. That's the gold standard. But unfortunately, the CPAP has a very low compliance rate. Okay? Second being the devices, essentially the mandibular advancement devices. Third being the surgery. Again, very, very difficult to plan this surgery and to convince the patients to go for this kind of surgery. As a general dentist, I'm talking, okay? So, CPAP, of course, being the gold standard, but very low compliance rate, very, very low. If you see many of the reports, more than 50 to 60% of the patients, they don't actually wear this. They buy it, you can get it very easily nowadays, but they won't actually wear this and use it. So it just goes pretty much for a waste. But for those who can do it, it's very successful also, okay? Then comes the lifestyle modification, again, easier said than done, okay? Weight loss, positional therapy, as you can see in the photo. Positional therapy as in you're restricting the patient from changing their position while sleeping. Okay? So some patients, they say that they snore only when they are supine. So you put them. So those kind of things you can try, but then again, the compliance rate is very, very less. Okay? Then for today's focus, we will focus more towards the mandibular, because that is, as dentists, as general dentists, we can very easily do this. So this is nothing new. Dentists have been doing mandibular advancement for a very long time now. Okay, we have many orthodontic appliances, we have anterior repositioning spints, okay, we have deprogrammers. Essentially all of these, they change the position of the mandible anyways. So mandibular advancement comes very much in general dentistry. So this is nothing like a very specialized or a different kind of a field. Okay, so here for this presentation I will focus particularly on one device which is called as a DreamVent. So this particular device is essentially a mandibular advancement device. Okay, it's available there in the stall. If you want to take a look at it, you can take a look at it as well. So what this device essentially does is, it looks like this. Okay? It looks like this. So it's a completely customized device, completely customized. So it's like not the ones which you get on Amazon where your patient can mold it themselves, put it in hot water and mold it. No, nothing like that. This is completely customized, 3D printed nylon device, which has to be manufactured in the laboratory and then provided to the patient. Okay? So that's the DreamVent. As you can see in the picture, you have an upper device, you have a lower device, and then both are connected with a band, and then you have a plug in the front, that is the valve in the front. You can or may not use it with the plug as well. Okay? So this is the device as such. Okay? So as you can see, when the patient breathes while sleeping, so either the patient is going to breathe through the nose or the mouth. So generally mandibular advancement devices, they fail because the palate becomes dry. If the mouth is open, the palate is going to become dry. If the palate is going to become dry, the patient is going to wake up from his sleep. It's as simple as that. Okay? So you can just imagine, even if I talk for a long time, my palate becomes dry and I need water or I need some sort of a moisturizing in my mouth. So essentially what this device does is it propels the mandible forward, and then it also allows an airway through the port. So it's a patented device. So you can breathe through it. So this is how it works, very simple, easy to understand. So if you look at it, the Difference between this particular one and the other devices is that this is a customized device. So it is like a custom tray, only for that particular patient. Nobody else can use it. Completely, perfectly fitting for that particular patient. It comes with those walls. Now, as I said, the dentist may or may not use the walls, but by default, always you will get a wall, that is the medium one, okay? And you can change it based on the patient's acceptance. So the patient has to be in constant touch with you. So you cannot just send away the patient forever. Okay, like you give the package and you send them. It's not like that. So you have to deal with the patient for a long time. So a lot of recalls and a lot of visits have to be done with these patients. Okay? So low, medium, and high. So what do you mean by this low, medium, and high is the pressure that it happens, the pressure. So when you breathe in, air goes in, that's no problem. But when you breathe out, that's when the air is restricted from going out. So this can be described in some terms as the EPAP, or the expiratory positive airway pressure. Just imagine if you close your mouth and nose right now and try to breathe. So what will happen? You will generate a pressure inside the mouth. So that is known as the EPAP, or with expiratory positive airway pressure. So based on the number of holes and the intensity of the device, so this pressure can be altered. So by default, you will be getting the medium one when you prescribe this patient. So how do you actually use the mandibular advancement? So there are many devices, even the customized one. So if you give it to the lab will already have some sort of an anti-snoring device. But it will not always be one with an airway. So that's the procedure. So once you decide to use it, the good thing about this device is that it's completely digital. So you don't have to take any impressions, no putty, light body, and all that. You can do it. I mean, if you want to send an impression in a cast, you can send that as well. But the labs, they prefer the digital way. That is the use of the intraoral scanner. Okay? So I'll give you this document. That's not a problem. So you can go through it. So what do we need basically? We just need the upper scan, we just need the lower scan, and we need the bite scan. So 3 scans. So in case you are not comfortable with scanning, you call the scanning technician to your clinic, and the technician will do the scanning. So those, they are already trained for this device. They know how to do the upper and lower scan. But the expertise of the practitioner will be required in taking the bite scan. So that time the dentist has to be there in the clinic. So you can't just not be in the clinic when the scans are being done. So you have to be around. So for normal patients, 95% of the patients with class 1 occlusion, you can do the normal bite. Okay? So I have a question for all of you, since you have, except for prosthodontists, one question I'll ask you. How much can you raise a bite? Roughly. Maximum, how much can you raise a bite? I know this, again, ambiguous. Okay? You can tell any answer. 2 mm, 3 mm, or 5 mm, okay? Not more than 5 mm, definitely, please. Huh? Please don't raise the bite more than 5 mm. And if you raise the bite anteriorly by 5 mm, how much does it get raised posteriorly? Around? Less than that or more than that? Less than that, right? So it will be always less than that, around half of that. So this device is designed in such a way that it will raise or open up the bite by 5 mm. So when the patient wears it, the patient will have around 4.5 to 5 mm of mouth open. So that is the situation. So this is how you use the bite fork essentially. So bite fork will be in the mouth of the patient, okay? And patient has to be a dentate patient, okay? It should not be a completely edentulous patient. Patient should already have a bite. So patient should have enough teeth in their mouth to have a bite for this device to be fabricated. Okay? Cannot be done for a edentulous patient. So this bite fork goes between the upper and lower central incisors, okay? Or if the central incisors are missing, then you can probably, even with a small RPD, it can be used. But there has to be a stop for the central incisors. So once you get this, the technician is going to put the scanner in the mouth and he's going to scan this bite, scan the bite, okay? So this is what will be done for most of the patients, 95 to 98% of the patients, this is what will be done. But if you have a patient who is having a lot of prognathism or retrographism, in that type, you have to change it. You have to go for a different type of a bite for which we have a single side bite. So these things, they will be provided, of course, to you by the manufacturers. They will provide you this bite fork, so you can take it. So single-sided bite fork is a little bit more complicated to use. Okay, very briefly I'll describe it, and you can get the documents for this also. We'll give it to you. So this single-sided bite fork comes with a gauge called as the George gauge. Okay, so this is the gauge. So this gauge goes and fits into the bite fork like this. So this is the bite fork, and this is the gauge. Okay, it goes and fits into it, locks into it. Then you put it in the, you keep it at number 0, you put it in the mouth of the patient, and then you ask the patient to retrude as behind as possible. Like how when we try to push the patient behind for a centriculation, we try to push him as back as possible, retrusion, you do that. And then you check the reading, ask the patient to go as forward as possible, you check the reading. So you'll get 2 readings. So if you have done, if you must have studied, right, Gothic arch tracing, no, how it works in the academics, Gothic arch tracing, it's something like that. So if you push the mandible backwards, the needle will go forwards. If you push the mandible forwards, the needle will go backwards. So you get those 2 points, and then you calculate around 50 to 60% of that distance, and that will be your maximum protrusion. So this is the documents that will be sent. Digital scan with bite fork in place, okay? And this is a checklist for to send to the lab. So not more than 5 mm clearance, and everything else should be there. The teeth should be there and all. And then you have to send a photo of the patient with his right hand raised, okay, to assess the midline. The photograph is important, okay? You have to send a photograph. After this, the manufacturing will be done, which is 3D printed nylon, okay? It is known as selective laser sintering. So this procedure is used only for polymers. It is not like DMLS. DMLS is used for the metal, it's additive. This is also an additive technology, but used only for polymers. So this is 3D printed nylon. And you will get the device. So once you get the device, you will get it with this band. Okay? This band by default will be a 19 number band, okay? 19 number. We'll just tell you about it. So when you get this band, you have to attach it and insert it. Inserting this processes, or I won't call it a process, this device is not easy, okay? The patient has to be trained. So you have to spend, as I said, a lot of time with the patient for this, okay? So you have to insert it, it fits like a clip, and then attach the band. Or if the patient has a good mouth opening, the patient can insert it with the band as well, because the band is elastic, okay? Removing is the same way. You are going to remove it, you can remove the band and remove it, or if the patient has enough mouth opening or dexterity, the patient can pull out the device themselves. But it will be very accurately fitting, as it is a custom 3D printed device. So the first day when the patient removes it, you might get a call at 6 o'clock in the morning from the patient, okay? He's saying that, what is happening, doc? I removed this device and I'm not able to close my mouth, okay? I'm having difficulty. So that time, before you give the device to the patient, you have to train the patient to do this morning jaw exercise, sugarless chewing gums, or just wait for a few minutes for the mandible to be repositioned. Because the patient will be sleeping for at least 6 to 8 hours, at least 5 to 6 hours, right? So 5 to 6 hours by wearing this device, the patient will have difficulty in closing their mouths, okay? For this, you can provide a repositioning splint to the patient, called as the morning repositioning splint. So this can be provided, and the patient can very easily go back to his normal bite, okay? So as I said, you will get the 19 number band by default, 19 number, less firm band, okay? Less firm and more firm, so that you can change it as and when you need. But if you feel that you want to change the protrusion, you can always do a procedure called as titration. So after 7 to 10 days, you can change it. By default, you will be getting at least 5 to 6 bands with you, because these bands have to be changed every 1 month or 1.5 months, because they lose their elasticity. So once you do this, you can go to the 18, 17, 16. So more you are going lesser, the more the mandible is getting advanced, till the point where the patient is comfortable. If the patient is okay with 19, fine. You never usually go backwards, you always go forwards. Okay? So that's the simple procedure for this. And the titration protocol, as I said, will be done every 7 to 10 days based on the patient's feedback to you, okay? So band replacement has to be done monthly or every 40 to 45 days. Okay? You have to identify whether the bands have to be changed or not, okay? Regarding the cleaning and maintenance, this lukewarm water is enough. Okay? Don't want to use toothbrush and toothpaste, because it's 3D printed nylon. It might damage it. So just the regular lukewarm water is more than enough. And you might have to purchase those sort of brushes to clean it, okay? It has to go inside the device and clean it properly. Okay? Done? So that was it. And you can also use it with the antibacterial cleaners, but it should be free of chlorine or acetic acid. So what patients can expect is dryness, of course. The first reaction will always, may not be very good, okay? First reaction will always be like, I'm having difficulty, because nobody can be so comfortable by wearing these advancement devices, okay? You have to counsel the patient a lot for this. Excessive saliva. So if you put a complete denture, you know that the saliva increases. RPD increases saliva. Same way, this is going to also increase the saliva. So morning jaw exercises and the repositioning splints should be used ideally with these. And you should not ask the patient to force close, okay? After just a few minutes should be enough for the patients to close. Fine. So these are the possible reactions to this, okay? The device is uncomfortable, I don't like it. That is the most common problem with this device. Patients say, I just don't like it. So again, a lot of reassurance has to be done. Patient has to use it for at least a month. 1 month, if they use it, then it can be called as a success or a failure. Okay? So these are the different situations that you will feel. And most of the problems, they will be solved by counseling of the patients. Right, so if you want to know more about the device itself, we have these numbers. Just saying is not enough. Suppose if you want to use it, you can probably just WhatsApp or give a call to these numbers. Okay, and there is a channel which is created as well, since most of you use social media. So you can check it out. Just type it on YouTube, you'll get it. And also there is a website for it as well. Okay? So that's about the advancement devices and a little bit about sleep apnea and its inclusion in the general dental practice. So with this, to conclude, I would just like to say that we need more things. We need more weapons in our arsenals. Okay? We need more things to in our practice. We need to expand it. So there are so many other things. If you open the lab brochures, it's not just about crowns and bridges, okay? Not about dentures or implants. There are so many other things that can be incorporated into dental practice, especially like sports guards. Okay, we have Brux checkers, deprogrammers, easy bites. These are all devices that should be given to patients, and these devices allow you to counsel the patients for other advanced treatments, okay? Something like aligners or implants and all. Slowly, slowly, the patient will become a part of your practice by using these additional devices, okay? So even though it's a morning thing, I think most of you would have gotten something out of it. So this is a QR code, okay? I like to give away my PPTs, okay? So if you just take a picture of this, or if you just scan it, the PPT will be there in your phones. Okay? The PPT will come into your phones, or you can just save it. Okay? So you can go through it later as well. Okay? So it's not that you have to forget what we said. So you can go through it later as well, right? Got it? Okay. You can just share it among yourselves. And finally, these are my contacts, since it's the first time I'm visiting here. So please be in touch. Okay? Regarding our lab, if you have any issues, you can always let us know, or in general as well. Okay? So that's the number. That should be, I think, okay. The WhatsApp number is there. With this, I would again like to thank the organizers and all of you for your very kind and patient hearing. And I hope that you just try to incorporate some of these additional things in your general dental practice as well. Thank you, and all the very best to all of you. Thank you.
Abhishek, I'd like to thank you so much on the behalf of the organizer, because we started late and you had a time about an hour, but you finished it in 40 minutes straight. And a very good presentation, at the same time maintaining the very good time. And I hope the audience also have learned something new. And before I ask him to leave the dais, any questions from the audience? Yes, please. Yeah.
Good morning, sir. I am Dr. Shabnam. I am a pediatric dentist. So it was a wonderful presentation. Like we also, like we are getting a lot of children. Like in India, 35% they have found in a study that they have SRBD. 5% are children. And what we have found out that we can screen the risk factors of obstructive sleep apnea, but many a time we have to send it to the ENT surgeons or sleep physicians to diagnose, because polysomnograph is the gold standard. So when we do as a pediatric dentist, we also collaborate with the ENT and sleep physician and find out what is their HI and what is their oxygen concentration, and if they want adenotonsillectomy, then they do adenotonsillectomy. Along with them, we do arch expansion or other myofunctional appliances and exercises. So I just wanted to tell that as it is for also all general dentists, so just by finding out through questionnaires, it's always advisable to go for a diagnosis by sending the case to an ENT surgeon or a sleep physician to get a more confirmed diagnosis through polysomnography. Thank you very much.
Totally agree with you, ma'am. You have to send it to the ENT surgeon, definitely. So after the questionnaire, the next step will be that only, the polysomnography. In this, what we have noticed, especially in Bangalore, what we have noticed is that usually when the patients go to the ENT surgeons, they usually never return back. That is one of the things that happens.
Sir,
So-
I would like to say nowadays
yes,
the ENTs are collaborating with us.
Yes, yes.
So many where I am also working in a private hospital also, I'm in a college, also in a private hospital. So there the ENT team, whenever they get any cases with children up to 13 years, they made it point that send it to a pediatric dentist or an orthodontist before going for an adenotonsillectomy. They think ethically it is right to first send it to a pediatrician or an orthodontist, and if they tell that okay you can go for adenotonsillectomy and AHI is much less and we can correct it by just by arch expansion and we don't have to go for an adenotonsillectomy, so our nowadays they are
Yeah.
sending lot of patients.
I agree,
So
I
this
mean,
collaboration is very important.
In pediatrics, definitely arch expansion is one of the best ways to do this, whether it's surgically or non-surgical. The arch expansion part definitely is there. For general dentists, I mean, what we usually recommend is, as in when we bring it to the general dentist, this particular appliance. So the aim is to just motivate them to just ask a few extra questions. Just motivate them to incorporate it in some way. Then collaborate with your sleep, because most of the general dentists, they don't know the sleep dentists and they don't know it. So just to form that bridge between the general dentist and the sleep dentist, and of course in corporates and all, we have the specialists, of course, the orthodontist, pedodontists and all. So this is like forming a bridge between both of them, and definitely both can do very well in this particular field.
Thank you.
Thank you.
Good question. Anybody else? Yes, Mike, please.
Good morning, sir. So I wanted to know that this mandible advancement devices, as you have spoke, so will that affect the TMG on a long run?
One of the most commonly asked questions. Actually, I was waiting for someone to ask this question. So TMJ thing is, now this device is going to be worn for max 5 to 6 hours. Okay, max 5 to 6 hours. Not going to be worn like a repositioning splint or something. So generally, from doctors who have used it, I'm not quoting any study or anything, but for doctors who have actually used it, and at least 50% to 60% success rates they have seen. So TMJ problems, essentially, if you get a patient with a lot of bruxism and a lot of such sort of things, in those patients, definitely you will have some problems with this particular device. But for general patients who have normal class 1 occlusions and all, I mean, till now we have not seen anyone with the issue. Only thing is that when you remove the device, that is when the repositioning has to happen. That it takes at least a minute or two for the patient, not like immediate. It takes at least 1 to 1.5 minutes for the patient to get back his bite. So that's the reason we are providing the repositioning splints with it, and we have providing that that strip. There's one silicone strip as well, which the patient can bite and reposition it. But in general, TMJ disorders, I don't think can be caused because of this particular device.
Any other question?
Sir.
Yeah. Good morning, everyone. Just to add a little bit to the TMJ thing, I routinely practice this. Of course, I don't use the DreamVent. I make my own appliance. And I've been doing it for so many years. I've got the George's gauge with me. What happens is, one thing we have to remember, the advancement that we are doing. How much is the advancement that we have done? It has to be, as per the George's gauge, it has to be 40% of the complete extrusion that the patient can do. So we calculated, he showed you that photograph where he had the intrusion and extrusion records and he calculated 40% of it. That's very important. The muscles have to be used to it and you have to give a training. So what I do is when I give to my patients, I tell them generally to wear during the day for an hour, 2 hours, during the day, and then they go at night to wear it. Because if you tell the patient directly to wear it at night, the discomfort may cause a rejection to the appliance. So it's better during conscious hours they wear it, get used to it, and then start. As he rightly said that there is going to be salivation, there's going to be a lot of, body response to that new device. So you have to give them in conscious hours so that they can wear it during unconscious hours at night. So that's generally what I follow, just to give you a little bit of idea to it. Thank you so much, Jared. It's a lovely presentation.
Good. Thank you, Abhishek, for a lovely morning session. And with this, I hand over the mic to.
So that was a fantastic. There's a last question of the day.
using two appliances on the maxilla and the mandible. If instead of using the mandible, if I make an acrylic plate for the maxillary and protrude the mandible in edge to edge and record that bite through acrylic on the anterior and the posteriors and let the patient use. So what happens during sleep, the patient will be using that plate by protruding the mandible. That is locked there. And no question of deglutition, everything remains all right, no gagging. So does it, is it usable, or your device is better than this?
Okay, I got the question. So the question is, what sir has asked is, if you make an acrylic device just with heat cure acrylic or cold cure acrylic, and you lock the mandible completely, like a full device, edge to edge, and you lock it completely, and the patient wears it and sleeps. Yeah. Yes. Yeah. What? Yes. Yes. Yeah. 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 But that's sir. Yeah. Yeah, sir. What I feel is, if you do that, that won't stop the problem of snoring at all, because you know, it will, the mandible will be anyways free. Here we have that band, which kind of keeps the airway open. In such situations, if the patient sleeps, obviously he's not in control, the soft palate and the tongue is anyway going to fall back and obstruct the airways. So it might not be that successful, I feel, this type of device. So many dentists have tried doing it themselves. A lot of dentists who have 3D printers, even they have tried to manufacture the device, this particular device. But the thing is, since it's done by that selective laser sintering, that particular technology is very, very accurate. So when it fits, it really fits like amazingly well. The normal heat cure and cold cure acrylic will never fit that accurately. So that is one of the things. Yes, yes. The device is, I mean, I would say it is, it's a very usable device, but of course the patient's first reaction will not be very encouraging. So it's for dentists who can convince the patients and who can counsel the patients to use it. So we have around 60 to 70% success rate with this device as of now. So maybe you can try it once and we'll get the feedback on that. Thank you, doctor.
Thank you very much. So I would like to call upon the chairperson, Dr. G.R. Ashok, to kindly facilitate our speaker. I would like to call upon Captain Dr. Debashish Haldar to come up on the dais and facilitate our chairperson. I would like to now call upon Captain Dr. Debashish Haldar sir to kindly introduce our next speaker. Thank you very much.
Good morning, everyone. As it is customary, I would like to introduce our next speaker, Dr. R.D. Das. Currently serves as the Director of Indian Academy of Aesthetics and Functional Rehabilitation and Professor of Practice at D.Y. Patil College and Dental Sciences, Nerul, Navi Mumbai. He embarked on his dental journey at GDC Aurangabad, graduating in 1993 under Dr. Balasaheb Ambedkar Mahabharata University. He pursued his excellence, led him to earn a postgraduate degree in prosthodontics and crown and bridge from KLE Institute of Dental Sciences, Belgaum,
Hello, hello,
affiliated with Dharwad University.
hello.
Dr. Das has made significant contributions to the field, serving at the center head of Illusion Training and Education Center and conducting specialized training programs in aesthetic and functional rehabilitations since 1997. With a remarkable teaching career spanning over 25 years in prosthodontics as head of prosthodontics at Dr. G.D. Paul Foundations, YMTDC, he has mentored numerous accomplished graduate and postgraduate students. Dr. Das has further honed his expertise through international training program, including certifications of aesthetic and functional rehabilitation and functional occlusion. He also holds leadership positions in dental societies and is currently the editor of Dental Dialogue, the official journal of IDA-MSB. He also has an impressive list of publications and presentations at both national and international conferences. As a fellow of the International College of Dentists, Dr. Das continues to inspire and educate in the world of dentistry. He is the proud recipient of the Charka Award for Clinical Excellence in Prosthodontics for the year 2025. I welcome Dr. Das. The stage is yours.
Thank you. মাইকটা চলছে? মাইকটা চলছে আমার? Can you hear this? Hello? Hello? হ্যাঁ। Someone needs to call Sudarshana. I need her password for the presentation. পাসওয়ার্ডটা চাই আমার। Sound. না কানেক্ট করছি খালি সেলফি তুললে চলবে না, আমার লেকচারটাও শুনতে হবে, প্রশ্ন জিজ্ঞেস করবো পরে। হ্যাঁ ওখানেও পেছনে যারা যারা সব মোবাইল দেখছে আমি কিন্তু প্রশ্ন জিজ্ঞেস করব, হ্যাঁ? It has to be interactive. We have a small crowd, it's so good, it can be interactive. না, যেখানে বসে আছে বসে থাক, সে কোনো অসুবিধা নেই, কারণ আমার চোখ সবার উপর আছে। স্লাইড চেঞ্জার আছে? I'm not understanding what is happening to this. Thank you. দিয়েছি উনি দিয়েছেন একটা, চলবে। Yeah. No, no. এটা কি হচ্ছে ভাই? এটা বন্ধ করলে চলে যাচ্ছে ওটা সাউন্ডটা। Somebody come and help here. সাউন্ডটা আইডেন্টিফাই করছে না এটা। The thing is, generally আমি আমার ল্যাপটপ ক্যারি করি। Last 8 days I'm in Kolkata, so I didn't want to carry my laptop. So I send the presentation here. And you know, that's the wonderful thing of digital world today. You know, that's why I always feel you have to stick to your analogs also. You do not know when the digital thing will fail. And that is why you should learn the analog in colleges. You know, students today tell me that, so why are you teaching us all these redundant things? When the world has become digital, why we need to take an alginate impression? Why do we need to take a compound impression? But believe me, friends, till you don't learn that, you will never learn the digital era. You know, I'll give you a wonderful example of that. Dr. Suresh Meshram, a few of them will know him, was sitting on the first row. He's a pioneer teacher. He always gives this example that গাড়ি যখন চালাতে শিখি আমরা, ঘরে হয়তো অডি আছে, মার্সিডিজ আছে, কিন্তু গাড়ি শেখার সময় মারুতি 800 বা সুইফট ডিজায়ারই শিখতে হয়। চলো, কি হলো ভাই? No, there's a slide before this, yeah. আরেকটা slide আছে before this. It's not identifying there. Sound আসছে? তারা আমি করছি, কিন্তু এখানে আছে দেখ, সোর্সটা বন্ধ হয়ে আছে এখানে। এখন তো হচ্ছিল। দাঁড়া, আমি বুঝেছি। কিন্তু এক্ষুনি তো হলো। না না, সিলেক্টও হয়েছিল না, তো লাইন ইন আছে এখানে। না দেখ, এটা না ভলিউমটা অফ হয়ে আছে, দেখ এখানে, এটা হচ্ছে জিনিসটা। লাইন ইন আছে তো। এখন প্লে করলে আসবে। অ্যালাউ করতে হবে, এটা অ্যালাউ হলো দেখ এখন ভলিউম টেস্ট হ্যালো হ্যালো ঠিক আছে দেখি যা নয়তো we'll just put the mic down and do that. Achha, it's okay, chal, dhyan hai sir. But the thing is, the testimonies. Can you try something else? Can I just? I have a pen drive. Can you try with that? No, ekhuni hocchilo to. The thing is, I'm not interested. The later slides, there are testimonies of patients which I want you all to see. ঠিক আছে চল ছেড়ে দাও এটা বার করিয়ে দাও কোনো লাভ নেই সো good afternoon Kolkata and I must first thank the entire team of IDA West Bengal to have selected me to come here and lecture. It's very nostalgic for me to come to Kolkata and to lecture because my roots are from Kolkata. I'm fourth generation settled in Maharashtra, Mumbai, but coming to Kolkata always feel homecoming to me. So thank you so much, sir, and everyone, Shubhra sir, all those who have selected me to have come here, and it's going to be a wonderful time and a remarkable, memorable time for me. So the topic today that I'm going to do is Roadmap to FMR, Analog, Digital, and Smiley Statal. So basically what I'm going to cover is, when FMR that I'm going to talk about is not implants, I'm going to talk about tooth-supported FMR. Because somehow today, moment FMR comes, everybody talks about implant-supported FMR. But what we are forgetting is that we are supposed to treat the tooth. And it's very important to treat the tooth well so that we don't need to put implants. So that's what I'm going to take you through. This is also not working, I think so. So I always like to start with taking the blessings of the Almighty, because all that we are is because of this Almighty who keeps blessing us. Then I like to take blessings of my mother, because she is there to bless me, and today whatever I am is because of her. So I always like to take her blessings before I start my presentation. And one person who made my life, who is my mentor and my postgraduate teacher, Dr. Jayant Zabde, sir is always there to bless me. So I always like to start my presentation by dedicating all my presentations to him, and he's yet there to bless me for all my endeavors. Nextly and most importantly is my family, who spares me on every Saturday, Sunday to be there for the IDA activities and my lecturing. That's my wife, Dr. Vaishali. She's there with me in the audience over here. She's an oral and maxillofacial surgeon. On the left to me is my eldest son, Dr. Omio, who's finished his MS in oral medicine from University of Bristol and currently working with the NHS. To the right is my younger son, Shrimoy. He's done his graduation from IHM Mumbai and has done his post-graduation from Switzerland in culinary management and finance, and was working in Dubai and is now in Mumbai looking out for a new venture. So that's my little family. And that is, I would like to talk to you about orthodontics. This is a platform that my wife curates because if you remember dentistry, every definition of dentistry starts with the art and science. So she believes there's a lot of art that we dentists can do. So we all dentists, most of our dentists have certain artistic skills. So she curates those dentists who are artists. She promotes them to go ahead with their art on the international platform. So that's her platform. You can follow her on Instagram on that. And most importantly of all, there is one person who misses me the most. Yep. That's my girl, my little girl, sweetie. She's the only one who feels bad when I'm leaving from home, and she's the only one who's looking forward for me to go back home. So I always like to show her. And there are a few people in the audience who have met. Kamal sir has met her. So she's my heart. So I always like to show my presentation with her. And one thing that probably my CV, when I was reading the CV, most of you must have not heard it, I'm sure, because it's such a long CV, it's very boring to listen to it. But I always don't like to cut short this CV, because when I was in your position, and I would hear these CVs of people presenting, I always felt, my God, these people have achieved so much in life. It takes a lot to put right things into the CV. When I say right things, because nowadays I see people putting a lot of unwanted things into the CV. But friends, let me tell you, a good CV is a motivation for you students, especially the young crowd that I see here. Dentistry is a wonderful world. I came to dentistry by default. I wanted to become a gynecologist. I wanted to deliver babies, and now I'm delivering dentures. So I'm delivering something at least. I'm happy that I'm delivering something. Okay, and this is my passion. So as you say, my younger son has done his hotel management because he took up my passion. I love cooking. Cooking is my first job in the morning. I'm a house husband. I manage the kitchen at home, and I've done a few episodes on a Marathi channel called Sam Marathi. So that's a little bit about me. Next, this is one proverb that statement that I read when I was in 2017. Today we are in 2026. 2017, my son was in the third year dentistry, and I knew that it's high time I collect my pockets because he was doing his BDS at Naya Dental at a municipal college. It's like a government college. And I knew that probably he'll come out and say, Dad, I want to do my post-graduation and I want to do a lot of things. And we did put a lot of money into dentistry at that time. So I said, I've always worked hard for the family. It's time I put something into me. And when I heard this proverb that he said that you have to go out and expose yourself to the best of what others have done and then bring some of it back and add to what you're doing. So this motivated me to go ahead and do my few trainings. I did my training with the Dawson Academy, where I learned the crux of dentistry. Let me tell you, friends, one thing that we miss in dentistry is occlusion. And if you want to do good dentistry, you have to understand occlusion. Now, how many of you have read the Wheeler's textbook, the backstagers? Very good to see so many of you raising your hand. Which is the chapter number 13 of Wheeler's? Chapter number 13 on Wheeler's. 13 is an unlucky number, na? So we don't read that chapter. The teachers also don't teach us, yeah? You know what is the chapter? That's a chapter which deals with occlusion. It's the only chapter which deals in occlusion in dentistry. Entire dentistry you're taught occlusion only in that chapter, and that chapter is never taught in dental colleges. That's the irony of the situation. Okay? So I went and understood what occlusion is all about. Then, in 2017, I had the crave to save dentine and enamel. Today we all are doing minimal invasive dentistry. Today it's the norm. But 2017, when we first thought of it, it was something which was rare. Nobody was doing it at that time. 2017, I went ahead, I did my training from Mauro Frediani. My friend here will know. Some of you may be knowing, I've read this book on Mauro Frediani. He's the grandmaster of minimal invasive prosthodontics. I did my training, Unfortunately, labs in Mumbai or in India were not giving you prosthesis like this. That was my drawback when I trained myself and went ahead, did my training in the Edelweiss system. And then most importantly, যখন শ্রী রামকৃষ্ণ স্বামীজির মাথায় হাত রাখেন তখন ওনার একটা ব্রহ্মজ্ঞান হয়. I equate this with my experience with Maria. She taught me the concept of Smiley's dentist. So though I'm not an ardent follower of the system, but I use her philosophy that she told me. So I'll tell you what she said. I was 2017, the first digital conference happened in Mumbai, organized by Dr. Ajay Kakkar. And I was too, since I had done my training in digital dentistry, I was a few who were practicing it. So he told me, Ratan, you must come ahead and talk on digital provisionalization. So that's a new topic for me. I was sitting on the first row. Maria was presenting before me. That's a very interesting story, guys. Listen to me. And she looked at me. She was talking about something that you can look at a person and tell what is the occlusion of that person. Look at the face and you can tell what occlusion the person has. As surprised as all of you all were, I was equally surprised. And all that came to my mind was, these white-skinned people come to our country, say something, and we all have said, oh, wow. We are very, yet, the British have left us in 1947, but yet we are crazy of that white skin. That's the irony. And if you see, most of my friends here will tell me that you can identify Dr. Das. He's always wearing a jabba kurta. He never wears Western. That's exactly what happened in 2018. I quit Western outfit because I felt that it's the biggest imperial slavery that we are doing. We are wearing their culture. We have a wonderful, rich culture. Thank you, sir. Thank you, sir, for giving me this opportunity, sir. Thank you so much, sir, for joining here, sir. Thank you so much. Okay. Okay, sir. So that's the reason I quit. So coming back to Maria, she said that look at the face and you can understand the occlusion of the patient. I was surprised. And as her presentation got over, Ajay got up, Dr. Ajay Kakkar, those who know him, he has this habit of being very interactive with the audience. He told Maria, just pick up a few people from the audience and tell me about their occlusion. I was sitting on the first row and she had realized I was not looking at her presentation. So she picked me up, she put me on stage and she said that I've got bilateral group occlusion. And I was shocked. How can a person whom I've not spoken to, a person who was not close to me, can tell me my occlusion? And that's where I learned more about it. And 2019, oops, when did you sleep? Why are আবার পাসওয়ার্ডটা কি ছিল? আচ্ছা 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 এদিকে যাবি না? So, and then in 2019, I trained myself into the Smiley's concept. And ever since I did my training, my attitude towards dentistry has changed. I'll tell you what happened. Today what I practice is more of holistic and holistic dentistry. There are two words I'm telling you, holistic and holistic. What is holistic? I see dentistry as a whole with the patient. How the teeth and the face correlates to the entire body. I'm going to talk about it a little more by the end of my presentation. And holistic is because if you see my cases today of FMR, I don't do a single preparation in my patient's mouth. I do minimal preparations because I consider them to all be my son and daughter and not my wife. You understood what? Laugh then at least. Smile, man. Wake up at least. I'm cracking some jokes for all of you. Though my wife is sitting in the audience and she would say, "Aata dikha to dojhe, ghar chalo." Okay? এগোচ্ছেই না। হ্যাঁ হয়ে গেছে, এসে গেছে। So coming to my topic, full mouth rehabilitation. What is full mouth rehabilitation? Full mouth rehabilitation is a highly individualized treatment. The point of a full mouth rehabilitation plan is to optimize the health of the entire mouth, including the teeth, the periodontium, and occlusion. In many cases, it is necessary to replace or restore every tooth in the mouth using a combination of dental treatment. Now here what most important is we should look at these 2 points, periodontium and occlusion. That's where we mostly neglect our full mouth cases. We do not have a look at the periodontium. Unfortunately, many periodontists I know do not practice pure periodontics, they will talk about implants. But I always say in an audience that if a periodontist does his duty, if an endodontist does his duty properly, I don't think so you need to put implants. So what is more important is when we are rehabilitating, we have to take a watch on the periodontium and on the occlusion. Whatever good prosthesis you do, till you don't give them a good pink aesthetics, you have not taken care of the periodontium, this prosthesis or treatment will never last in our patient. What we need is once I've treated, the patient should be happy, should be comfortable, should be able to use those prostheses. That will happen only when we have taken consideration to the periodontium and occlusion. So, the various methods of doing full mouth rehabilitation that I'm going to cover today are basically 3: the traditional analog method, the contemporary digital method, and the futuristic smileless method. So what I'm going to today cover up, I'm going to take you through 3 cases where I have treated in a different way. So remember one thing, what happens is, moment we talk about full mouth rehabilitation, something that comes to our mind is we have to treat all the patients in centric relation, or what we need to establish is centric occlusion. Remember, that is not the requirement of every case. When a patient has come to you and he has a comfortable MIP, what do I mean by MIP? If I just tell my patient to close, he is regularly going and closing at a particular place. His MIP is complete, is comfortable, he has no problem, there is no TMJ problem, the occlusion is perfect. What is the problem? Is probably the aesthetics or the anatomy of the teeth are bad, which you need to correct. So these are going to be the idea, 2 things. In that case, do not venture out to take that patient to a new occlusion, treat the patient in that occlusion. That's what I'm going to take you in the first case. In the second case, I'm going to show, of course, in that case, though we can do it digitally, I'm going to show you the traditional analog method. Because here there's an audience which may not start with digital. I want all of you all to do good full mouth cases, so you can do it the analog method also. So the first case will deal that. The second case I will show you wherein we are going to have a complex case which we have to correct the occlusion, establish the centric occlusion, and go ahead and treat the patient. And the last one is the futuristic Smilex concept. We'll keep it till we come to that patient. So what are the steps in full mouth rehabilitation? The basic steps are impression and bite registration, face-bow record, mounting on a semi-adjustable articulator. Absolutely important, whenever you are doing full mouth rehabilitations, you need to use a good articulator. You need to have a semi-adjustable articulator. Provisional diagnosis, whether you need to deprogram the patient and deprogram and fabricate a jig if required. Remount after deprogramming, eccentric records, incisal table customization, diagnostic wax up, mock-up, mouth preps, adjusting the occlusion, provisionals, final impression, redo face-bow record. So that are the typical steps. If you see, there are around 17 to 18 steps which you need to follow when you are doing a full mouth rehabilitation. In the first case, let's see the traditional method at MIP. So for this, let me take you back to Dr. Pankey. Dr. Pankey was the father of full mouth rehabilitation. He told us, he gave us the basic principles of full mouth rehabilitation. And what Pankey has to say, I never saw a tooth walk into my office. What does he mean by that? That don't look at just the tooth. No tooth walks in, it's a patient who is walking in. And you have to understand these things when you're treating a patient. Okay? So the operational sequence, typical operation sequence for a case, you take your photographs, that's your photographs, intraoral, extraoral photographs. You do your wax up, whatever corrections you need to do, and do a mock-up in the patient's mouth. Then through the mock-up, you can do your mouth preps. That's the restorations in place, posteriors. I always prefer to finish the anteriors because that's where the incisal guidance is set in case you need to change or you need to establish or maintain the incisal guidance. Always do your anteriors first, then go ahead and do your posteriors. You do your posteriors, finish with the posteriors. That's the final restoration, and that's the pre-op and post-op photograph. This is just a very, very simple case wherein what was the requirement? Patient wanted aesthetic and anatomical correction of the teeth. That's all that the patient wanted. So we went ahead and simply treated this case. Patient was not getting married because of her teeth. Moment we did it, she got married in a month's time. So our treatment was successful, right? And I got a good serving of biryani from her. Huh, sir? Next is another case. A friend of mine comes. You can see his complaint was the lower anteriors that were wearing off. Occlusion was proper. He went ahead, did our records, did the mouth prep, and finished the case in normal PFM cases because the patient could not afford zirconia. So patient wanted PFM, so went and finished in PFM. Now the contemporary digital method wherein we are going to record CR for our patient and treat the patient at CR. Let's see step by step. So to understand this, let me take you to Dawson, who said don't change what is right to fix what is wrong. That's exactly what I told you. If the patient has a good occlusion, don't change it. Only when it is wrong, change it. That's a very famous saying of Peter Dawson. Step by step, let's see how to do. So if you see slowly, as we proceed from contemporary, from analog to contemporary, the number of steps are reducing in your treatment modality. Okay? So analysis, we do our scans. So if you notice, the patient has got a pseudo class 3 occlusion. Why am I telling pseudo class 3? When I did my diagnosis, the patient was able to go to class 1, but patient was habitually closing in class 3. Why the patient was habitually closing in class 3? Because the posteriors were missing. So patient had to bring anteriorly to close in occlusion. Did my models, my photographs. That's those are the phonetic analysis that we do. We always do a phonetic analysis to know what are the corrections which are required. Did my Facebook records, and I realized I need to put the patient on a home deprogrammer. So there's an anterior deprogrammer which is made. It is a customized anterior deprogrammer for my patient. And why did I realize? Because when I was placing the patient, when I was clinically deprogramming the patient was able to come to class 1 but was not able to maintain it. So I had to put a patient on a home regime. The period that I put this patient on a home regime was 3 months. So 3 months the patient was put on a deprogrammer. So that's what I wanted to show you all actually. Now when I took the testimony of the patient, what the patient says, I'll tell it out to you all. Patient says that I feel comfortable wearing this appliance. It's almost 2.5 months after he has used the appliance. He tells me that he's comfortable wearing this appliance, but when I remove the appliance, he says when I go to sleep, I feel I'm going back to my earlier position. This was the testimony that the patient gave. Now what does this testimony tell you? There are 2 things. One, I realize the patient is sufficiently deprogrammed now. Patient has come to a comfortable position. But he had a saying that but when I lie down on the bed, I feel I'm going back to my earlier position. So when the patient is not using the deprogrammer, remember whenever you give a home deprogrammer, patient should not wear it at night. Patient has to only wear it during conscious hours. Unlike the sleep apnea device which you saw before this presentation, you have to wear it at night. This you don't wear it at night. You have to remove it. So when the patient doesn't use the appliance, patient was going back to the earlier position. Now patient has learned two positions, the class 1 relation and the pseudo class 3 that he had. Go ahead, do my wax up. For that, can you see that? Can you see the difference in the bite that the patient is giving you now? Patient has moved from class 3 to class 1. I scan at this position. You can also make your impressions, not an issue. Take that bite, did my digital wax up. Again, what I don't like is digital wax up because I don't have a free hand on Exocad, so I can't correct if I need anything. Secondly, these scans are not digitally, they're digitally articulated. What do you mean digitally articulated? The software just closes them like my hinge articulator. Whereas it is not put onto a semi-adjustable articulator. There is no digital occlusion that is obtained. So when I put it on my articulator, I realize there is posterior opening. I had to correct it with analog wax. I corrected with analog wax. Go ahead, do the mock-up in the patient, and it is at this stage, that you decide what type of preparation you are going to do in which tooth. Why? Based on the thickness of your mock-up material, you will know whether you are going to do an add-on technique or a subtractive technique, whether how much I have to reduce, whether I really need to do my endo. Unfortunately, most of the time when you go for full mouth rehabilitation, we all jump to do endo in all the teeth. But if you do a good mock-up, you'll realize that it's not necessary many a times to do endo on most of your teeth. Go ahead, finish with your collaterals, choose your material of choice, do your preps, do your provisionals. That's the provisionals in the patient's mouth. Now what has happened is, I have moved the patient from pseudo class 3 to class 1 position. Can you see the change in the bite? Now these are on milled provisionals. When I say milled provisionals, they have to be high quality provisionals that we give our patients. Why? Because we are training the patient to this new position. We have to put the patient under a home training program. Imagine the patient was closing like that. I am now telling the patient to close here with my appliance in the mouth, with my restorations in the mouth. So if I immediately go with my final restorations, what will happen? My final restorations will fail, or I'll have sleepless nights trying to correct those restorations. So when you put these provisionals, there is a disclaimer that we put to the patient that these provisionals will have a lot of problem. They will need to be changed again and again. You have to come back to me for all of it. So we put the patient on a 15 days recall, if required shorter than that, and patient comes and we keep changing the provisionals as and when required. And once the patient has settled with the provisional, you know what is the provisional period this patient was put on? Any guesses? Anybody, any guesses? Any Prosto PG students here? Any clinician who can guess? The patient was put on a 6 months provisional. Imagine, look at the age of the patient. He was 70 plus, very adamant patient. So we need a lot of time for him to get adjusted to this new occlusion. Okay? So we put the patient on a 6 months provisional period. He came back once. There was no problem. 15 days, no problem with the provisionals. We go ahead, scan the provisional, scan the restorations again, scan the provisional, scan the restoration, scan the bite, go ahead and finish the restoration. Yes, sir? In his case, few of the restorations had to be changed couple of times, 3 to 4 times. Oh, sir, you should have listened to his testimony. That's the reason I wanted you to listen to his testimony. The name of the patient is Mr. Ashwin Bhai Kamdar. He's an NRI, Gujarati. He had all the qualifications to trouble a dentist. And with the treatment, he had bought my kidneys, and my livers came complimentary to him with all of it. And every time the patient came in and used to come to my clinic, I used to see on the CCTV, I and my assistant started doing pranayam. We learned pranayam because of him, because he would come in and then start. Ye kya kiya? And the best part, this patient was referred to me by my wife. So that was again an added qualification to the patient. So he goes back, he calls my wife, that your husband did this thing to me. And at night, I had a second round of treatment modality going on at night. Why? Ashwin ne kam there is chilajge? Ki bollo? And then you know what happens after that. So I don't need to tell that. So that is how it is to happen with him. But with all of it, almost 9.5 months, I put all the restorations in the mouth. What do you expect, friends? That okay, now next 15 days the patient will be seeing me every day because he'll have hundreds of complaints. And I saw him 48 hours post restoration, and the patient was absolutely comfortable. You have to hear his testimony. Unfortunately, the presentation is not playing. It's not playing. You should have heard to this testimony that he is also told that halfway through the treatment, he was deciding to leave the treatment. He felt he has come to a wrong dentist, and is happy that I could treat him. Everything went fine, and post his treatment, I treated him in January 2020, and COVID happened. So he had paid my bills. COVID happened. He never came back. So I thought two things must have happened. Either he's very happy, or COVID has helped me. He's taken the patient away from me. So I thought the second was more probable, because knowing the patient, he would have called me up every day. But he just didn't get back to me. Just 48 hours post this thing, he was comfortable, he never came back. But after the first round of COVID, he referred 3 patients to me. So I knew he was living and he was happy with my treatment. Yes, sir? From the? No, not from the other world, sir. Not from the other world. Not from the other world. From this world only. So I knew that he was happy. He was comfortable with the restoration. 6 months back, he comes back to me. He gives me a call and says, Dr. Das, I want to. Oh, before that, most important of all is this last treatment modality, post-op care. I'm sure most of us clinicians here will agree that one thing that our patients ask, কতদিন চলবে ট্রিটমেন্টটা? চলবে তো? করলে সব ঠিক থাকবে তো? জিজ্ঞেস করে কি না পেশেন্টরা এখানেও? সবাইরে জিজ্ঞেস করে তো? তো আমার একটাই প্রশ্ন থাকে। পেশেন্ট কি বলি? You have to come every 6 months for prophylaxis and checkup. So when we buy a device or a TV or anything, those disclaimers they put, that the warranty and guarantee is subjected to this. So my warranty is subjected to the patient coming every 6 months to me for prophylaxis and checkup. Terms and conditions apply. Now, let me ask you a question. How many of us in this audience get every 6 months prophylaxis done? How many of us? So in an August gathering of dentists, I don't have a single hand coming up which says that only one, madam and husband must be a dentist. That is why, So যখন patient থাকে না তখন নিচে ধরে ক্লিনিক করে দিই। আমি মজা করছি madam. So imagine around 50-60 people sitting in this hall, I have only one person, one dentist who's telling of 60 dentists who goes for cleaning. So do you really expect my patients to come? They don't get a call from my clinic. I don't want to call them. Abel, mujhe maar nahi karna hai. If they call up, they come, they get a prophylaxis done from me. So that helps me as a disclaimer. And if my patients truly come, there are certain patients who come regularly, they come every 6 months, they are on a proper follow-up. Do you really think we'll have problems with those cases? We don't have. A little bit of whatever little thing, we can solve as and when it comes. Okay? So that's one thing. Then 6 months back, that is almost 5 years after his treatment, he calls me up and he says, Dr. Das, I want to come and see you. I said, ke jane ki hobe, shop kota daat hate niye asbe ki bolbe jani na. Luckily, he came this way. He just had one crown which was dislodged. I replaced that crown and he was comfortable. So you can see a 5-year follow-up of a typical case where there is no wear of the restoration. Everything is fine. So the secret behind this success, I'll tell you, is not me, but my provisionals. The secret was that provisional that we did and we tried it out. There was a good trial round that happened. You know, Ashirwad আর বিয়ের মাঝখানে সময় রাখা উচিত। পিড়িতে আশীর্বাদ করলে বিয়ে অনেক সময় থাকে না। তো ওরকম বুঝলেন না, এটা ওরকম হচ্ছে। আশীর্বাদ করে কিছুদিন রাখা উচিত, দেখা যাক যদি বরের সাথে জমে কিনা। So that's what you do. You allow the restorations to be comfortable in the patient's mouth. Once you replicate that, you will not have a problem in your cases. Okay? That's his testimony. Now, the last thing that I want to cover up is the futuristic Smilist method with the Smilist bite. So what Maria has to say, the Smilist is the result of my obsessive passion to relate the facial musculatures with the movement of the mandibular teeth in harmony with the maxillary teeth, and how the maxillary teeth serve as a guide to the only bilateral connected joint of the human body. So let me just tell you briefly what she has to say, that our entire facial musculature is developing or develops based on our occlusion. So let me just simplify this further. We go to the gym, guys, girls go to gym nowadays. Gym has become a very common thing. What if we take different weights on both the hands? What will happen? My biceps will grow differently on both my hands. Right? So always the trainer will put you on the same regime on both the hands, both the legs, because both of them work independently. Whereas our joint, whatever exercise it is doing, what is the exercise it's doing daily? Occluding. His exercise is to occlude. So the path he takes, it's very simple. The condition of our cars in the Indian roads. What happens when I drive on Indian roads? Thanks to all the potholes, thanks to all the irregularities on the road, either my suspension of my car gives way or my tire gives way. Worst come worst, the entire car will break down. So let me equate it. There is the maxilla, there is the mandible. The mandibular teeth are riding on the maxillary teeth. They're driving every day on it. If your occlusion is not right, your mandible is going like this. So what will happen? What is the suspenders? The muscles of mastication. They will get affected. Worse come worse, the TMJ will get affected. Or the tires are the occlusal surface of your teeth, which will get worn off. So that's exactly what happens in all of us on a daily basis. Okay, that's what this entire concept is all about. So let's see, you can see now how the steps have reduced. Right from 16 step, I've come to a treatment modality which takes me not more than 4 to 5 steps to finish my full mouth cases. First is analysis. This patient comes to me, look at the occlusion of the patient. He comes to me with a complaint, a very typical complaint this patient has. Again, my wife referred this case to me. You know, oral surgeons get a lot of TMJ problem cases, so I get a lot of these cases from her to me. She goes to my wife, this patient goes to my wife. The story goes that he was a banker with Yes Bank, and he was to undergo arthroscopy because he had severe tinnitus in his left ear. He could not raise his left hand. He was diagnosed to have psychosomatic disorder. He was on the verge of a divorce with his wife because continuously he kept complaining of tinnitus. He went to n number of ENT surgeons who said there is no problem in your ears. Then finally he happened to go to a maxillofacial surgeon who posted him for a arthroscopy surgery. Now he was telling it to his colleague that from tomorrow I will not be there in the bank, so kindly manage my patients, you know, my customers. You know how these private banks are, they have their own customers. So he was handing over to that boy, and that somebody who had come to deposit cash overheard this. And he said that if you have a joint problem, at least see Dr. Vaishali once before you go under a surgery. So yet today we do not know who was that person who referred that patient to us. Why I'm telling you, it's very interesting. He comes, my wife sees at her center, she was working in a center near the bank. She sees the patient, she says there's no problem in the joint. And she had faith that I can help the patient. She calls me up frantically. She calls me and says, I'm sending this patient and you need to see the patient immediately. And because it was a Thursday, I was not in the clinic, I was cooking at home, all my gases were on, and I was cooking, I was sweating, and not had my bath. But she said, I'm sending the patient just now, you see the patient just now. I said, I'm in clinic nahi, because at that time the time is for someone else in my clinic. Bole na, tomake patient dekhti habe because patient has to go surgery tomorrow, so he has to cancel that appointment. So you need to see the patient. So she sends the patient to me, I do my preliminary diagnosis, I take her photographs. No, I did not even take his photographs at that time. And very interestingly, he tells you all about his problems in this, which I told you already. And I do his, I'll come back to that testimony 1 second. I do his examination. So can you notice something, friends? Can you see his shoulder? Now look at the first photograph, look at his shoulder. His left and right shoulder are at different levels. You see that? When the patient is standing, the patient stands with one leg in front, one leg behind. He's not standing straight. Can you see that? These are all involuntary photographs. Patient did not know what I'm photographing. Okay? Look at the way the patient is standing. Can you see this? He's standing like this. This all is happening because he's trying to balance his mandible to a comfortable position. Can you believe this? I'll show you how it all gets corrected. Can you see, if you see closely, can you see his face? From a bird's eye view, the left side and right side of the cheek, they are different. This entire development of the facial musculatures are happening differently because of the occlusion that I showed you. Did you see the occlusion that the patient had? You see that? That was the occlusion that the patient had. When I looked at it, when I saw this case preliminarily, I thought I'll need to go for ortho, I may need to go for tabletops. This is what I thought. Okay? Went ahead, did my diagnosis. Sorry, this is very interesting, you can see this. Just see. Can you see the mandible? Can you see the mandible taking an S-shaped path? Now notice his left eye and right eye. Can you see his left eye is smaller than his right eye? Look at his left cheek, look at his right cheek. Look at his nostrils, they are at different levels. That has happened because the facial musculature have developed because differently on either side because of the mandible taking that wrong path. Okay? Go ahead, did my Facebook records. I manipulated. This is what I did on day one when I saw the patient. The later photographs are later on. All I did is I took the mandible, guided that mandible on a straight path. I just told the mandible to close in a straight path. I was guiding it, not his occlusion, not his muscles. And miraculously, all his complaints vanished. All his complaints vanished. I have a testimony of it. Moment he tells that, I knew I can treat this patient. So what I did, I went ahead. This is what the entire Smileys concept is all about. So this is post-Smileys maneuver, what he has to say, that the entire thing vanished. Of course it will come back. Moment I leave it, the mandible will come back. So I need to treat it. Went ahead, did my Smileys correction. So these are different types of bites that you need to do. In this case, because the mandible is moving on one side, I needed to guide the mandible in a unilateral side. I gave a unilateral bite device. So generally what I do is I give first in soft wax, hard wax, and acrylic unilaterally. I do that, I'm training my patient slowly to close it, because if I suddenly tell the patient to close over here and lock the patient over there, patient will never be comfortable, right? Go ahead, prepared. Once the patient is comfortable and is able to, without the appliance, able to close and open and close, I take a bite over there and I created, this is the occlusion that I'm getting of my patient. You can see, if you go back here, one slide, I'll go back. You can see there is certain amount of disocclusion which is there here, certain amount of disocclusion which is there over here. So I need to correct that. Gave the patient an appliance. Patient uses that appliance. Once he's used this appliance for a good 15 to 1 month, 15 days to 1 month, he needs to wear it. Now the patient is able to open and close. Now here, patient doesn't need to wear it all the time. You tell the patient when he's not doing anything to wear it. So he can wear it. Even in office, he wears it only when he's not doing anything. When he's not talking, he's on the laptop, he can just go ahead and wear it. He was very happy with the device, and the device was done by my lab. I actually recorded the testimony. He was so happy because this device for him was like God sent to him. Imagine a person who's about to go divorced, getting a surgery, everything improved because of this one device. His entire problems were gone. He got his wife back. And what I did after that is, once his all complaints are gone, go ahead and did my mouth preparations. So what mouth preparation I did? I used my occlusins. Those who attended Rumpa's lecture yesterday, she spoke in details about it. I use it regularly in my practice. I used it. I found wherever there are prematurities, I removed all those prematurities. 3 sittings in a gap of 8 days I took with the patient, and that's the occlusion that the patient has settled into. Complete occlusion, patient is comfortable, all problems gone, he is comfortable, he is at a regular 6 months follow-up with me for last 5 years. Patient is absolutely comfortable with this tool, right? So, went ahead and finished his post-op care. Just one more case, very interesting, same type, you can see how the patient is standing, okay? Same way, you can see the torsus that he has. Same torsus, see how he is standing, see his shoulders. Again, a very interesting patient. Patient comes to me from an ophthalmologist whom I treated, and this patient's brother was going to that ophthalmologist. He's an NRI. He came to India to fly his brother back because no TMJ expert in Mumbai could treat him. So he wanted to take his brother to the US to get treatment done. Similar problems, patient had totally withdrawn from all activities. He stopped going to college because if you see what is happening with the patient is this. You see that? Can you see his sternocleidomastoid was throbbing all the time? Can you see the darkness around his eye? He would have sleepless nights because of that. This is the complaint with which the patient comes to me. Right? I do my provisional diagnosis, go ahead, treat him. That was his, that was his occlusion. I'm surprised nobody talked about his occlusion. Can you see this occlusion table? Look at the occlusion that the patient had. I did my deprogramming. Moment I deprogrammed the patient, can you see the shoulders have come to the same level, the hands have come on the same level. Now the patient is standing upright properly. Immediate, just deprogramming the patient with a cotton roll, it showed its results. Did active orthodontics, I put the patient on aligners. Did active orthodontics, 6 months, I put him on active orthodontics with aligners, finished his occlusion, corrected his occlusion, and see the change that the patient has today. So that's where I started with the patient and see the upright position that the patient has today. So that's where, without a single restoration, just by good diagnosis, holistic approach, that's what I started my presentation today, that I finish my cases, most of my cases today, firstly is seen by an orthodontist. I feel in our full mouth cases, please involve your orthodontist. Today, fortunately, our orthodontics has become much easier than what it was earlier, because you really don't need to put brackets, you have aligners, You can, intrusion, extrusion, all has become so comfortable. There's a time when there was an intrusion and extrusion, we would just say that the patient has to undergo, elective endodontics. It's like murdering someone because he's not performing properly. We can't kill a tooth because he's in the wrong direction. We need to rehabilitate him, push him back in position, right? That was his testimony. Very interestingly, I'll tell you, last month, December, his brother got married, that brother who brought him to me. And the best part is he came with his brother's wedding card to me. And his mother had gone to the temple that day with the wedding card, and he came to me. He said, "Ma gache mondire, ami eschi apnar kache." He was a Maharashtrian. And I felt so touched, I'm getting goosebumps even now, ki you're almost equated to God when you treat well, when you actually do the right treatment. So I told him, please don't do that. It's too much of a thing for me to take. You go back, let mummy finish off the formalities of giving it at this thing. You come back to me one day after. He of course came back, we attended the wedding. And that's the way, when your patients have faith in you and you're able to do good treatment, I'm sure your patients will always remember you. Okay? So with that, I'd like to come to an end of my presentation. And that's where I said, today when I do full mouth rehabilitations, I do more of holistic and holistic dentistry. Thank you so much. Any questions? So either people are not, when there is no question, there are two things. Either no one has understood everything or everybody has understood everything. The first one is more important, I think. So. Thank you so much.
Okay. Thank you, Dr. Das.
Just 1 minute, sir. So I'd like to finish with this one saying that I'm not handsome, but I can give my hand to someone who needs help because beauty is required in the heart and not in the face. So I conduct these full mouth cases. Anybody is interested, they can get in touch with me. I have senior teachers like Dr. Kamal who has attended my course. So if anybody is interested, you can go ahead. You can come ahead and attend it. That's the details of the course. It's a 2-day hectic schedule. Those who have done it, they know how hectic it is. It starts from 9 in the morning, goes on till night 9 o'clock. Last time sirs had a flight to come back, so they had to leave in between the last part of it. They had to literally rush through it. And so thank you so much. That's my contact details. You can get in touch with me. Thank you so much, sir.
Okay. Thank you, Dr. Das, for the wonderful deliberation. And as there is no question, so thank you everyone.
Now, I would be honored to have our chairperson to felicitate our esteemed speaker.
Can I have Dr. Shubhranandi sir with me on stage?
Yeah, yeah.
And Shidhanshu sir. Sir. Shidhanshu sir. Ashul Nektu. It will be an honor for me to have you with me on stage. Thank you, sir. So one more thing I'd like to tell you about this bouquet. The 2024 conference that happened in Vishwa Bangla, we were given the same bouquet. I yet have it at home. So that's a wonderful idea. So this is the second one is going to add to my... So I yet have the 2024 one at my place. Thank you. Thank you, sir. Thank you.
Now, I will request, sir, please felicitate our chairperson. Now, I am requesting Professor Dr. Pampadya ma'am to please come forward and introduce our next speaker.
Good morning. I have to introduce now Dr. Vivek Hegde, sir. Dr. Vivek Hegde is an alumni of prestigious MCODS, Manipal College of Dental Science. He is also Masters in Dental Lasers from University of Vienna. At present, he is the Vice Principal and Professor and Head at M.A. Rangunwala College of Dentistry, Pune. Faculty for lasers in Vienna and adjunct professor at various colleges in India. An acclaimed academician for 26 years, he has more than 100 publications and contributed in more than 10 books. He is a microendodontist par excellence. He has presented India at prestigious platforms like American Endodontic Congress, USA, IFES Seoul, and APAC New Delhi also. He is an invited speaker at various forums and conferences on both international and national platforms. He is a member of editorial board of various journals. At present, he is president of SOLA, Director Indian Board of Endodontics, and also was the past president of IES. He is presently the CEO of White Urge Dental Care Pune, Dental Center Pune, and One Dental, an online teaching platform. A passionate teacher, an inspirational mentor, he is also an avid sportsman, fitness freak, and doting father. Thank you, sir. Start.
Thank you so much. Thank you for your kind introduction. I'd like to first thank Anirban Bhattacharya, who invited me here for this event, and of course Raju Bishwas and the whole team, Dev Shankar, and many, many people to thank here. Thank you so much. Can you increase the volume? So I'm being given a topic to speak, and the topic is about magnification. So this is about 10 M's in magnification. Just give me a minute, please. I don't know why this is. Abhi dekho. Okay, SDM hai dekho. हो गया अभी हो गया था. No. As long as it doesn't come on the screen, it's not okay. I need it. Do they have any other connector? Any other connector hai kya dekho, because it's not picking up. Or they have to, you have an iPad, Mac ka? Mac अगर है तो इसमें वायर I don't know why, because मेरा computer is picking up. USB, they have to put, but they're not an HDMI then. That'll be something else. USB मतलब मेरा HDMI का कैसे करेंगे? C to HDMI चाहिए.
वरना पेन ड्राइव में ले लेते ना?
नहीं है, वीडियो है, काफी है.
Let's see if your one works there, in the other one.
Wait, वहाँ जा सकते क्या? वहाँ लेक्चर नहीं है ना?
नहीं, वहाँ पे लेक्चर चल रहा है. So let me see. The other guy has got another connector over there. If your connector works there.
Okay, but you'll.
मैं ले लूँगा.
उसका ब्रेक करना पड़ेगा लेक्चर.
नहीं, वो चालू नहीं हुआ अभी.
ठीक है, देख ले.
We'll just see if that works there.
हाँ. But I don't know with this wire. Every week I present, it accepts. Last week was Mangalore, Diva Patil, it just picks up. The adapter, I think so. वो लेके गए नहीं तो मैं ट्राई करता. बस. I think इनका HDMI में प्रॉब्लम है शायद. ये वायर में अगर प्रॉब्लम है तो कुछ भी नहीं कर सकते.
HDMI वायर का प्रॉब्लम नहीं तो. ओ,
पड़ेगा?
अभी तक चल रहा था.
तो ठीक है. किसी ने मैक में किया क्या अब तक? नहीं ना वही ना देखो. उसको बोला अनिर्बान को बोला ना एडाप्टर का लेके आना था. मैं टेस्ट करता हूँ. आपके पास कनेक्टर नहीं है? आपके पास कनेक्टर नहीं है SDR का? Surprising. बट कनेक्टर रखते हैं नहीं लोग, इनके पास भी रहता है कनेक्टर. नहीं, जनरली दिस पीपल आल्सो कीप कनेक्टर्स. उसको भी मैक है? नहीं, मेरा अल्लाह ने तो आई टेस्ट ट्राई फ्रॉम दिस. ये अगर एक्सेप्ट नहीं कर रहा तो गो नथिंग है बेटा. मैं लैपटॉप में कुछ भी करूँगा, मैं रेजोल्यूशन चेंज करूँगा. Not really. I can mirror it. There are options, but it depends on this. अगर ये ठीक नहीं है तो कुछ नहीं होगा. For Mac के लिए बोलो. I should have tested it. फर्क कुछ भी नहीं है. Just that दो क्यों रखना है? Every week I make ये तो repeat presentation है, but I make new. आज नहीं है, तो वीडियोस आते हैं, so many things are there. It won't take videos. Then videos का link देना पड़ता है. इसमें you can embed a video into the slide. Mac का इसलिए advantage है. In PowerPoint you have to give a link. Animation है ना? IT team है ना? हाँ लेके आया इसने. कुछ लेके good try. और क्या करना है ना, क्यों नहीं करेगा? ट्राई करो, अब देखो. हो रहा है? देखो. थैंक यू. चलो हो गया. Okay. Sorry for the break here, but I'd like to thank the Kolkata West Bengal branch for inviting me here. Greetings to all my teachers. Dr. Adhikari sir is here, Dr. Das sir is here, my good friend Dr. Mitra is here, and many others whom I know. So this is a topic which is very close to my heart. Thanks Anirban. It worked. He gave me another one, I think so. I think something is. Thank you. So, like I told you, I'm here because of Anirban. He invited me here on behalf of the local organizing team. So, this is a topic we would like to discuss. It's about magnification. What I want to tell you about magnification is how it's changed the game for me, and that's here it's true. There was a panel discussion that happened just before this. They all agreed how recent trends, how magnifications change the game. ये लाइट कम कर सकते हैं? लाइट कम कर देना. So basically, you're getting into the depth of the root canal system. The nooks and crannies of the root canal are not as simple. The straight canal, the straight apex is all gone. We all discussed in the morning, I heard them speaking about how it can be complex in many ways. So that's exactly what I want you to understand. The whole game of root canal is complex. So I want you all to understand that much. Try to understand that root canals have changed the entire gamut of treatment. But with the recent advances that have come in, so many things have changed. This is one of the workshops that we've been conducting in Goa, the IES conference, where I was doing a hands-on workshop where participants, they spoke about bioceramic sealer. This is a bioceramic sealer that we're injecting into the system to learn it. So that's exactly what it is. And this is a clinical practice, a right clinical setup of what I would do in my practice. This is a forehand dentistry that we would do exchange of instruments using of ultrasonics, which also was spoken about, for different procedures. So that's the beauty of magnification. But first things first, I got introduced to magnification in the year 2001. How long can I speak? Because I started late, so it's a lunch break. Yeah, all right. So in 2001, when magnification was not popular in India, one of my friend, I think all the Manipalites will know it, Chirag Sarkari was a classmate of mine. I told him, USA aate rahe, mere liye le aana. I didn't know what I was getting into. But I was doing consulting. Mera clinic bhi nahi tha. So consulting mein mere ko referral practice mein they used to give me difficult cases. So I asked him to bring a pair of loupes, which is Zeiss. He bought this. I didn't know there was 2.5, 4.5, 3, kuch nahi. He bought a surgical telescope. Jo mila, mila, kaam karo bas. But this is not the right thing to start off with for sure, but I did this. But this changed the way I looked at dentistry. Believe me, I became a constructive critic. I started looking at things, forget root canal. I'm going to show you a small simple filling. It looks so simple, right? It looks good root canal filling. It looks well matched, not my filling. My neighbor has done the root canal. He's a good dentist. I'm not putting down anybody, but see this. This is how aesthetic dentists will show the picture, 1:1. I was challenging the so-called Bombay aesthetic dentists, the big people. तुम मुझे 20x में दिखा के बताओ. 1x में कोई भी दिखाएगा, थोड़ा wet करेगा, सब कुछ blend हो जाता है. So the same picture I'm going to show you a little later. अभी इसको 3.5 में दिखाएंगे. See what's here. You'll see the whole lines and everything is happening. So what I would say is, don't have to go for 3.5x. Start with 2.5. It's a basic thing because the depth of field, the field of view is very, very different. It gives you a wide angle view and a lot to see. But start using a pair of loops. If there are young faces here, some of you, please start right now. Because seeing is believing. It will change the way you work. Like I said, it makes your work only better because you become a constructive critic. So in 2003 in my college, we bought a pair of microscope. But again here the problem was the same. I didn't know what we were getting into. Jo mila wo le lo, like college said, jo bhi sasta hai le lo. That's how. Again, we did our own mistakes. See the screen, you can't see anything. See the depth of focus. I'm sitting quite close. You're bending. Microscope is supposed known for ergonomics. So anything. This all happened. That's how we learn. Today you ask me, I'll give you everything about microscopes and loops. I know so much more. So anyway, the same 3.5x which I showed you, the same 0x. Now you see a 3.5x. I'll bump it up to 5x. You get loops in 5x also. You bump it up to 8x. Again, there are loops ergo now, which are 8x to 10x. I'm bumping up to 12x. See what it is. The same root canal, the same composite filling. I'm not talking about root canals now. I'm showing you 20x. In 20x, if you see, the filling was not looking bad, but that the white line, all the aesthetic speakers speak a white line. The interfaces, the bevel not given well, the blending is not well. Plus, you see that small little round circle, that's nothing but a camel brush. He's a good dentist, I told you. He uses brushes to brush on top. One of the bristle got left behind inside, in the composite. So after polishing, it's permanently there. So you use loop magnification, I'm sure you won't do these things, and you'll get better. The polishing and finishing of a restoration, okay, I'll put this example. I was listening to a speaker 20 years back. What he told was, I call the patient once after my composite is done for finishing and polishing, which means one extra visit. I laughed at him. I said, "Kya bol rahe hai? Kaun bulata hai again?" 20 years back. Today I do the same thing. The day you finish the composites, you do a gross finishing, good finishing, but you call in a week's time, do the final finishing, the finishing and polishing, which means it takes another 20-30 minutes to spend on that restoration. Such a restoration which is well done and well spent will last for a long, long time. These are direct restorations. Think different. That's what it is. You will not end up having these problems. Now I'll take the same picture which is 20x. This is microscope, okay? I'll take the same picture 20x to normal and everything looks good. So all I'm saying is, if you want to jump the level of greatness, if you want to go to that extra mile to be very different, get a pair of loops. Microscope, yes, but that's the next step. Not if you don't have the money or if you don't have the setup or if you don't have the patience to spend on you and otherwise. Just now they were speaking about the charges. It's personal, I feel. It's your worth. Don't put a price, put a value, please. Whatever your worth, that's what people will give you. And that's exactly how you develop your, cultivate your practice. I'm going to show you a small example of root canals now. I showed you on restorative, right? See root canal. It's a small procedure. We're doing H bond. That's it. When you do H is total H for composites. For this is like post and core. But see the amount of bubbling that's happening. It's vapor lock, negative pressure, surface tension, contact angle, jo bhi bolo. Blow drying, see, the moisture is not going. What has the book told? Etch the tooth, blow dry the tooth, put the bond. I wanted to remove the extra water out. Otherwise the bond is getting contaminated, diluted. So what did I do? I used bonding agent, I would absorb in paper points. Here's the bonding agent. How much bond? Very little. It's flooding, see this? How wet is wet? That one, I'm blowing air for air thinning or maybe drying, moving. Nothing is moving. And this is not very far. Just 15 millimeters far away from the surface. So my thing is, 2007, I learned a trick for myself. I was not doing all these things. It's now 20 years. After etching, before application of the bonding agent, after application of the bonding agent, before light curing, I will use absorbent paper points. Otherwise, what happens is, there's an island of the liquid, be it the water or the bonding agent. Your post is not going to full length, and even if it goes to full length, there is a thick layer. I want a micron layer, not a millimeter layer. So the bonding is going to get affected. Your post and core can fail. So try and blow dry with a Stropco if you have, because nothing is going to move from the root canal surface, and it's not even deep. So please use this. It's very, very important. So with microscopes, with magnification, it definitely showed me that I need to remove that extra bit, otherwise you're in trouble. A simple example of surgeries. I used to do a lot of episectomies. I still do. My first case in 2007 when postgraduate started in my department. I took the patient on a microscope. I said, okay, we will do a Peter Walworth incision, which means papillary preservation. Now you have a full thickness flap you remove, but we removed either marginal or submarginal. Marginal is what? You elevate from sulcular. Submarginal is what? Liu portion bean or scalloped incision, or now called papillary preservation. So this was papillary preservation. The first mistake what I did was, when I got in there, the first incision at the midline is wrong. The papilla which is to be best in the aesthetic zone, I tore it. Now I am supposed to suture it with 6-0 and see what happens. When I did with 6-0, I was worried, will that aesthetic zone help me? But believe me, the same picture I am taking at a microscope at 4x, 8x, 16x and 24x. I will challenge anybody if you can tell me where I gave an incision. This is 3 weeks later, of course. That's the kind of perioplastic surgery we do today. We use ophthalmic blades, we use 15C blades, we use microsurgical instruments, and miraculous is the healing. Maybe if time permits, at the end of it, I'll show you some surgeries. We're doing microscope-based surgeries, beautiful surgeries. So this is exactly what magnification makes me do. It changes the game, it uplifts your standards, standard of care for the patient and otherwise. So this is just an example of how a vein before a surgery could look under magnification of different magnifications. 0.4 would be about 2.5x, and 2.5 times is the factors could be about 20 plus x, whatever it can be, okay? So that's how it is. You also use a green light in surgeries because there are two filters. One is a white filter or the orange filter for composites. The other one is green filter. The green filter comes for soothing your eyes. You get fatigue otherwise. Plus, green is a contrast to red. So that gives, when you're doing surgeries, it gives a good contrast to your work that you do. So that's how it is. So I'm going to speak about 10 M's now of microscopes. My 10 M's I said. My first M is, when you're doing endodontics, when you're doing restorative dentistry, please invest in a good pair of mouth mirrors. When I say mouth mirrors, here they are like my image, they are my reflectors. Mouth mirrors are used not only for vision, for reflection, retraction, and many other uses, we know that. Now here are two mirrors, you see, both are different. In second year BDS, we use the left of mine, which is called a rare surface mirror. In a rare surface mirror, what happens? When you keep the tip of the probe, the image starts a millimeter too far away. Why? Because the silvering is at the bottom, not at the top. This is not the mirror we should use now. We should be using a front surface mirror where the tip of the tine and the image starts together. That's where I'm not fooling myself. That's the cheaper mirror. Student level, it's all okay. But today, if you ask me, go for the front surface. It shows you much more, much clearer. Yes, it can scratch, it can spoil, all that I agree. But the reflection of 40 to 60% more makes you see better. As we get older, I know our eyes is weaker now. You need supports. I definitely would use loupes, magnification, but aids like a mirror, like a mouth mirror. So this is called a front surface mirror. Now you can get coated, many rhodium coated, many coated ones. That is your choice based on the money you have. But the simple steel mirror also can work. So see what you want to buy. A mouth mirror which is front surface is the first thing you should change in your practice. Now when you use mirrors, you have plenty of them. You can give handle with one, or you can give disposable with one, like cone and socket or simple stem or whatever it is. Now I'm going to show you different mirrors. Now this mirror that I'm going to show you now is a single regular mouth mirror that I'm using, and I kept all my micro mirrors of my surgery in that. Now you will wonder for yourself how small a micro mirror is. Micro mirror is not used for regular work, it's used for microsurgeries, where you will take this small mirror of 3 mm diameter or 5 mm diameter above the root to see the root and preparation in microsurgeries. But they are very expensive mirrors. I don't expect anybody to buy now unless you are seriously into microsurgeries, right? But the regular mouth mirror is easily affordable to all of us. You get sizes 4, 5, 6, whatever you want to buy, from 0 it starts. 4, 5, 6 are standard. Now when you use work, understand there are two things now, direct view and indirect view. Wherever you can get a chance to use directly, please use that, because that's the best you can do, because then both your hands are free. In indirect view, what happens? You have to use a mirror to reflect and deflect the light and the vision for your eyes, which means one hand is locked with your mirror. You only have one hand to work. So that's not easy. So when you start work, I always say direct is the best. This is the direct vision. So everybody who starts magnification, like microscope or loops, will start with the upper tooth very easily, because upper we always use mirrors. The problem is with lower. I don't know why we work at the direct vision. 9 o'clock position, I may sit for the lower, fourth molar. I'm the right-hander guy. So fourth quadrant, I will sit at 9 o'clock suppose. I'm not seeing anything. Not even the floor of the chamber. Forget the root canals. But we've been taught. Even the lower incisor, we think it's easy. Believe me, I want you to learn the art of indirect vision. Which means what? You buy a microscope or loop, it's a secondary. From today, I want you all to use a mouth mirror. Keep it at the distal marginal ridge of the tooth. Use your eyes to look into the mirror and get the indirect view. If you start working the indirect way, right, everything that comes after that is yours. Just try doing oral prophylaxis. Go to the lingual surface and try do scaling. You will laugh at yourself. You know why? Because your hand is going right, but the mirror is showing go left. You try to put the file in the mesobuccal canal, it's going to mesolingual canal, because you're ulta hai. So the hand-eye coordination through the mirror to your brain, wo seekh lo. It will take few weeks. I know we have done hundreds and thousands of work, but wo karte karte na pasina aa jata hai. Try from tomorrow. Just simple thing I'm saying. Mirror use karna. Advantage kya hai? They're talking about rubber dam or not and all. Suppose there are practitioners not using rubber dam. Keep the mirror at the distal marginal ridge. File ko thoda protection to mil jayega. Kam se kam. That's not the right way to speak, but I'm telling you. But keep it at that point. So when you're using that, but look here. Kabhi kabhar idhar bhi dekh sakte ho, but idhar bhi dekh lo. So when you look at that, right, that coordination happens, your dexterity improves. Your maneuvering, that improves. So this is what I want you to learn. Keeping the mirror and looking into the mirror and not to the tooth. We say lower incisor you can see directly, not at all. That's the most difficult tooth. Especially I spoke about extra canals. Lower incisor has high incidence of extra canals. And lingual surface is tipped. You will think I'll go back and see, nothing you can see. You'll have to come front, look into the mirror and look ulta this way. That's the only way you can see a second canal which is under the cingulum, provided you did the incisally directed access. So that's what it is. So the second M after the mirrors is going to be micro cracks. The biggest advantage of microscope, you know what, is this. What it says is, suppose unaided eye is 200 microns. What happens high-end vision? It's 10 microns. What does this translate to? A normal eyes cannot see a micro crack. Patient will tell you I have pain on biting. Micro cracks are seen under only microscope, especially with magnification about 10x. Because eyes can only see 200 microns, not less than that. So 0.2 millimeters ke niche, eyes cannot detect well, no matter how good you are. So this is what will teach. So it helps you in diagnosis also. So I'll translate it to an example here. What it means, I'm using a normal view and a magnified view on a pen. Now you see, I'm doing a ball pen and a ballpoint pen. When you use that ball pen and a ballpoint pen, what we don't realize is the ink is released not from the tip. Ink is released around the nib of the tip. That's why you will find a white line in between. That's the sensitivity or specificity. Or see this example. This is my table on my preclinical lab. 2 feet distance but I drew under the microscope, okay, I must tell you. There are 2 lines, not 1 line. And now you see, I'll bump it up into 2 times, 3 times, 5 times, 6, 8 times, 12, and 19. This is a 6-step magnification, a global microscope. So we'll only speak out one thing. Now when we bump up the 12 times, you see here, Between that there is a white line. That line is the nib of the pen. Ink is released around the nib. That's the kind of specificity you will get with microscope. If you can see so closer, who cannot do it better? It's as simple as that. Seeing is believing, they say. So try to see that. For the younger audience, you have to work this way. There's no other way. If you want to be in the game, you have to be. We as seniors, maybe we have passed on our active phase and we're just sustaining and maintaining now. Right? But the younger audience, with the kind of technology that's coming in, AR, VR or AI, whatever you want to call, that won't help you. Your fundamentals will help you, your grassroots level basics will help you. And this only can be adapted. So understand that much. So here's one, this is an extracted tooth model. Of course, we are working for showing a demonstration in a workshop. I have stained the tooth with a dye. There are different dyes available. You have a blue color, green color, red color, whatever it is. What it does is, after a minute when you wash, it shows you the irregularities, which means interfaces between restoration. It shows the cracks, it shows extra canals, and many other things. So that's exactly why I think Dr. Das said, use a stain and you can possibly, try and detect few things. Now you have a blue color dye. I use it for this. Now you see when I use this, I used for a minute, then I use a polishing brush, I wiped it off, and then when we see the main canal groove, it says this is not seen in normal eye, there's a crack. Patient came with a classical example, I can't bite, doc. So I knew he can't bite. Now which tooth to hit? Is it 6, is it 7, is it 8? I don't know. So this easily helps me. I stained all the 3 teeth, I polished it, I went on the microscope, I said, oh, you know what, you have a crack here. Now how to manage it is a different thing. If the crack doesn't propagate full length, I can save the tooth altogether only by conservative. I don't need endodontics. Replace the missing part of the tooth, that's it. Maybe an onlay, maybe a restoration, whatever it is, that is the next thing. So that's how you possibly diagnose a cracks and a fracture. Now another patient came, I can't bite, doc, there's pain, but there was a lesion here. Now I know it's a long-standing one. I didn't promise him much. You know what I told him? Let me open it and see, and then I could see the crack here. I opened the filling, MOD filling was there. I stained the tooth and see what's happened. It's a through and through. If I try to do root canal here, I'm fighting a losing battle. The bone will follow the crack and you lose bone. Even the implant can come out, cannot come out properly later. The crest is going to go away. The crest of the bone is important for me. I like to work with collaboration and not competition. But at the contrary, please do not extract good teeth for an implant, please. Implants have come for replacement of missing tooth, not to extract a tooth and put an implant. That's the wrong thing. So this is going to go because the MOD through and through, right? So we didn't save. I didn't put the radiograph here. This is another green dye. Now you have another case here. See this, a pink color dye. A caries detector, but it can be used as a dye also. All I'm trying to say is, see the crack going through and through. Such cases may not be a good case to keep. I know you can use bands, you can use restoration crowns, all that fine, provided the patient is with you. Because you lose the bone, it's going to be a sad story. Here's the senior doctor of Pune who came to me. His son was my student. He says, doctor, kuch bhi kar lo, bacha lo. I couldn't do much. I said, sorry sir, nikalna hi hoga. So clinical picture here, you use the stain, you separate. Of course, I've injected him, otherwise he'll get pain. The same visit, we decided we're taking the tooth out also. So that was the decision. So you see there, it's moving. It's through and through. He's a Bruxer. His second molar already cracked for the same reason, it seems. He came for the first molar to me, even that's going. Now it's an implant maybe, yes. So the third M is about motors and rotors. Why I say this is because when you use this, motors and rotors, I want you to use long shank burrs, micro-head handpieces, because accessibility and visibility plays an important role in your work, which goes to say, when you don't use this, you're in trouble. That's not because of microscope or loops, even otherwise. The head of the handpiece is larger than your axis cavity. So normally when you do with your normal eyes also the same story. So that's why we as seniors do better and beginners suffer. Added to which there's air and water spray to complicate the situation. That's why every time we stop, oh I'm here, karte karte, we complete the whole story. So here, so please use long shank burrs and look in the mirror, indirect view, I can see the tip of the work that I want to do. The burr, where it should go and how it should go. I'm using a Muntz burr to find an MB2 canal. It's a long shank burr. My microscope is focused not on the handpiece, not on anywhere else, except the tooth, and that to the floor, because I bumped up the magnification. There are tips and tricks of how to do this, but it's exactly what you do. This I'm not expecting beginners to do now, but start your mind thought process. Think different. Like they spoke about heat treated files. Anirban was saying you can use heat treated. Of course you can. So you can pre-bend a file today. You have the blue files, you have the gold files, memory files, all that can be pre-bended. Then how does it matter? Is it 21, 25, 28? Any length is okay to me now. Pre-bend karke I can go where I want. I can just start the work just before I bind it. So these are advantages for you. Flexibility. Microsonics in endodontics is the fourth M, which means microsonic is a word derived from Cliff Ruddle actually. What he said is a perfect marriage between microscopes and ultrasonics. When ultrasonics came in, no, it came in a scalar. Everybody said scaling ke liye mujhe ultrasonic chahiye. Today ultrasonics is a power generator for me. We do many things with ultrasonics. In endodontics, plenty of use, from calcified canals to finding, removing pulse stones or chasing broken files to manipulating MTAs or irrigations or root canal surgeries, plenty of things, including crown remover, composite condensation. I can go on and on. So it's got many, many, many advantages. So think this way. Again, they spoke in the debate about ultrasonics. So here are some uses. The videos are very, very short, please, because I know this presentation is not about particular thing. It's about magnification. But because my head of the handpiece is not coming on the axis cavity, see, my visibility is so beautiful. Ultrasonic so thin, right? I can see everything in that. So I removed that pulp stone there. Now extra canal if I'm using, this is one of the device called StartX, with water and without water. With water will change your depth perception. So I'm using that. And we are finding that extra canal called MB2, which again they discussed and said that every other case has it, which is true, almost true. You get or not, I don't know. Or maybe another video on irrigation activation. This is ultrasonic activation, where possibly you are using a golden color file, a bland file for activating the irrigant. It's a long shank spoon excavator, no? It's a long shank spoon excavator, you get those, yes. Okay, his question is good. When we call it a spoon excavator, no, what we study in second year is not spoon, it's a discoid. But it's been taught spoon. Spoon is actually should be a spoon which you can scoop up. So such devices, such instruments you could use for taking out even pulp tissues. Like pulpotomy is a big thing now. You get in ultrasonics also called katana tips and other ones, but this is a manual one. You can get a manual one, please. So here, what did I say here? Okay, before this is the thing. Minimally invasive endodontics. Today is the day of MID or MIE, minimally invasive dentistry or minimally invasive endodontics, which means I want you all to understand one thing, that you want to cut less tooth structure. Again, they spoke about pericervical dentine, remaining dentine thickness, all those things. Please keep that as a core topic. Root canals fail not only because of the preparation that you do, but because of excessive cutting that we do. So I want you all to be tooth designers or not tooth cutters. That's exactly the slide belongs to. I don't want to be a tooth cutter. So let's understand what that means. Suppose you're doing a multiple visit endodontics and you've used a non-eugenol cement or a eugenol cement as a dressing on top. You have to give 2 or 3 dressing because it's chronic. I won't use a burr. You know what I'll do? I'll use my perioscaler. Perioscaler I'm saying. I want to remove the cement, that's it, right? So it was here. From here I'm using this one and I want to come to remove the cement. So the first day when I go into the root canal, we remove the entire caries. We do a pre-endo built up. After that there's no use of a burr actually. So that's what it is. Inside you want to give a Teflon, you want to give a cotton. Teflon is preferred, of course, that also spoke about. That's exactly what I want to stress about. So this is what it is. When you open axis cavities, please be like a tooth designer, which means I know it's caries driven axis. If you have a choice, save the strongest portion of the teeth. What are they? They are the cingulum in the anterior, the marginal ridge, the transverse ridge, the oblique ridge and the cusp tips, whichever teeth they can be. Unless otherwise involved, don't cut them, please. You want the tooth to last longer, that's the best gift you can give the tooth, right? So think different. So these are all axis designs which came in. They're all articles, okay, they came in. Now, we don't go in for all this. This is one design, the most conservative design. That's exactly where we got an MB2 also. And mesial driven axis. See, the distal, if you see here, we didn't even go to D-roof. Earlier we used to do a flare technique like this. I don't do that. I go from here. This area I can use an ultrasonic and clean up the area. There's a wall with the flow of the core built up, doesn't matter. But this is where I'll just build up a contact only with an onlay. Replacement the missing part of the tooth. I don't even do a crown today. I don't like the idea of crown cutting or tooth preparation. Too much of cutting at the neck of the tooth. The PCD is going. Because post treatment, you make a radiograph and you realize, what did I do? Where is the dentine? Because with zirconia asking 2 mm finished line, suppose. Inside we have done so much of opening. Where is the tooth? One day it's going to break like this and come in your hand. And that's a sad thing to say. There's nothing much you can do. So think different. I'm not saying don't give coverages. Give coverages. Give short clinical crowns. They're called onlays. Give endo crowns. Plenty of options today. But learn bonding dentistry. That's more important. If that you learn, things will change for you. We have to get away from the old dentistry, which is non-bonding dentistry. Think bonding dentistry, everything will change for you. So I'm not asking you to make these axes, please. These are called ninja axes. Just to prove a point, I did it myself too, but I don't do it anymore. Not needed. You're struggling your life for nothing. Right? Just not needed. They try to say what? See the rubber stopper, usse bhi chota hai mera axis cavity. Kis liye? Not needed. You know, there are papers after this saying that residual pulp tissue was left behind, which can be cause of a failure of root canal. It's not easy to clean the system. So you need to have convenience. Don't be too liberal and wide the tooth. At the same time, be conservative, yet at the cost of your convenience. I'm showing you various axis cavities here. Now we have axis cavities, even this one is labial. Kaun karta hai? I don't mind doing today. You know why? Because there's something called a straight line axis. If I start from palatally on the anteriors, go first 90 degrees, how books told us, then do 45, then turn, itna bada kar rahe ho aap. Cingulum bhi ja raha udhar aur incisal bhi ja raha. Not needed. Go more incisally driven axis today, anteriorly. I'm not asking labial, that's a guided axis. Guided is 2 types today, either with STL files or DICOM files, either it's static or dynamic. Stent bana ke kar sakte ho, or freehand bhi kar sakte ho with dynamic. That's all came because of implantology now. We have, you know, navigation devices. I have that with me. But all I'm asking is, when you open axis cavity, try and save the cingulum, don't go, they come more incisal edge, even if you have to touch the incisal edge. Your good restorative materials, you can save it. Even without touching, you can. Labial axis isliye kiya tha because I want to show you a straight line axis. Now, post-op, we made a CBCT. Now, this is a CBCT. We started from here, didn't even touch the cingulum. This tooth doesn't need a crown at all. A good restorative dentist. See the axis cavity design. Mesiobuccal, buccal. See the centricity of the canal. But this is guided, okay? I'm telling you frankly, freehand nahi hai. I've used guided access. To do or not to do is your choice. I want to catch up with the trends that's happening new. I always reinvest in my own dentistry with a lot of things. My first aim is what I earn, I put back into my specialty. So if you ask me what tool I don't have, I don't think, I keep on investing. Like we have in-house CBC for the last few years also. We have CAD-CAM, we have everything now. Because I want to go there. I'm very clear about few things. Like somebody asks, do you have a big car? Sorry, I don't have a big car, but I have big instruments in my clinic for sure, okay? That's how it is. So here, so this is what I mean to say. See the root canal at the end, it's not straight, it's coming buccally, which is never seen on radiograph. Yeah, dikh raha hai? Nahi, yeah, straight dikh raha hai. But see here, it's tilted buccally. And that study, if you from 1980s ka study, Cutler study, Green, Levy, everybody told you what? 2/3 of the time they open buccolingually. Radiograph mein aata bhi nahi hai. 1980 is what? 45 years before. Before many of us were born. I was born, but before many of us were born. So all I'm saying is that, तभी बताया गया था वो 2D में बताया गया था 3D नहीं था तभी, but that's what it is. So all I'm saying is think different, save the tooth structures, try and do minimally invasive dentistry where you don't need to cut more dentine, which means I want you all to keep at least 2 mm of dentine at the cervical third, 1 mm at the middle third, and 0.5 minimum at the apical third. If that much of dentine is not saved on a tooth, I doubt the tooth then. So that's what it is. You're managing additional canals. This is the topic that needs to be discussed with magnification, with the aids of CBCT. I don't take CBCT every case like how Adhikari sir said, not needed for every case, but it's an aid. You may need it sometimes. Like if a dense case comes, I definitely need to know the third dimension. A large lesion comes, I need to use the buccal plate, I need to use the palatal plate. Sometimes I'm fooling myself and wasting my time by doing non-surgical. But having said that, root canal has to be done if you want to save the tooth. So root canal comes in, then a CBCT comes in. When to do CBCT, you take a call, right? Now here are the different canals. You have middle mesial here, you have middle distal here, You have a C shape there, a dense invaginators, MB1, MB2, 3, all those radix, all those cases which I got in my clinic. So we keep doing all these things. All I'm trying to tell you is for the young people, for the young people you should need to know that plenty of extra canals are there, and these are the various extra canals you can find in different teeth. Try keep an open mind. Don't go anterior to one canal, premolar to two canal, aisa hota nahi abhi. You can get extra also. So these are few things you can get extra. So all I'm going to do is, I'm going to show you, we're just going to talk about one thing. Like they said, MB2 has got extra 100%. See the reports here, the old article, 95%, 92%. One is clinical, one is supposed to be CBCT. Whichever report it is. If it is 90, it's almost 100%, right? So that's what it is. So try and look for this MB2 if you can. So these are all the MB2s I got in my clinic, plenty of them. This is what I could put on the screen at least. We keep getting MB2s. We try and look for it at least. We don't give up on that. And there are plenty of tests. They spoke about probing tests and bleeding tests and champagne tests. All was spoken in the morning. So here are the few things that you can do. These are all book, okay? The book said it, not mine. But you still have to do it because you're all clinicians, but of course following the academic knowledge on it. So follow this test, few tests, any one, two is okay or all are okay. So quickly to start is a video of a model work that we're doing on a, I think for a demo. The burr you see which I'm using, SS wide long neck burr for axis cavity. Start from the, like Anirban said, larger canal, distal canal or palatal canal, easier to get, easier to numb, easier to for everything. And that's the end point. Come easily then. I'm using a yellow ring burr for my finishing of the walls. That's a bubbling test. See this? Champagne test. If there is tissue or there's any oxygen liberation, you'll bubble. You stain this tooth, the model work I told you. We found 3 canals, MB1, 2, 3. Then you use your rotary system, any system, glide path files, rotary files, hand files, combinations, all that works. It's true, if hand do not, rotaries cannot. They spoke about that also. So I was glad I was a part of it. It's a lot of revision for me. So it is good. So the model works. Here's 3 canals you are placing. A quick short video of this, of course, just for your information. Put a little sealer. Today it's bioceramic. So the whole concept has changed from sealing versus filling. So you need to understand what is sealing, what is filling. So that's where you are at a model work. Coming to MB2 for young generation, young audience here. MB2 is not difficult. In our time it was a novelty. You got very happy. Now it is no novelty. It is compulsory. But to get an MB2, only simple rule is what? I am talking about laws of Ranko or Krasner and all that, 2004. He said draw an imaginary line that connects the mesobuccal 1 and the palatal. The MB2 should be in front of the line or in line, but not inside the line, which means it cannot be towards the furcation. It cannot be towards the isthmus. It's away. Draw an imaginary line that splits the buccal and the lingual or the palatal half. MB2 always will be on the buccal and the mesial half because that's a MB root, unless it's a separate root. Third point is, if you want to know, MB2 horizontal plane is not in line with any one of the canals. MB2 is always 0.1, 0.2 or 0.5 or 1 millimeter or even more deeper than the horizontal level. That's why you end up missing MB2 because MB2 has got a lip of dentine that covers it most of the times. It's more on the wall, in the hideout, in the undercut. This is a micro CT sample. We did a study for something else, so I use this. So it's a good teaching aid, I thought. So youngsters, when you search, you always thin the mesial wall. You don't have to keep mesial wall too thicker because it's always in the wall. It's average of 3 millimeters from MB1. The other way of doing it is you draw a line and it will be perpendicularly matching, which means you draw a line from mesobuccal to palatal. The distobuccal canal you already got, no? Try and join that. Wherever you get a right angle is where you start digging. You get it? Mesobuccal and palatal, draw a line, imaginary line for that patient. Palatal say up, draw kar lo, they get a probe and try and meet it. Where it meets is somewhere there you'll get an MB2. So many ways to make out. So these are all the MB2s I got. One of the most difficult MB2 was this for me. You know why? Short, acute curvature. File will go in and not come out sometimes. So that's the problem. And if it can break also. So many things can happen. So longer, larger curves are easy. Angle of curvature they were speaking. 30 degrees plus, minus and all. So Schneider is one person who spoke about mild, moderate, severe. Read about it. Schneider's classification 1972. Both hai, but this is one. So the radiographic interpretation. In COVID times, I used to play around with extracted teeth because patients are not there. Let's go to clinic and play. So I stained. You know how many MB3s we got? See the portals of exit on that MB route. So what I mean to say is, always expect and accept extra routes and extra canals are bound to be there. Root canals are not as simple as you think, right? And the more you understand, the more you think what I was doing till now, right? That's how it is. So microapical clearing is one aspect of irrigation. That's the most important aspect. The only difference of the best clinician, you and me, is this: how much time do you spend on irrigation? And irrigation does not start from the beginning, please. Irrigation starts when you end. अब मास्टर कौन हो गया मेरा 3004 बोल रहे थे 3006 जो भी है. After that my irrigation, you know why? That 30 gauge needle should go to the apical third, 1 millimeter, 2 millimeter short of apex, and that's when you start replenishing the solution, irrigation, turbulence, the thrush that happens, all those things. So that's important. So plenty of ways. They also spoke about agitation versus activation. This is all about activation, it's written, but it can be called agitation because 100 times to do and shake the patient is not right. This is hand with file. You can do with a needle also. After depositing, like a pen you can hold and you can start doing this. This is all youngsters who are not wanting to invest money, who don't have the money now. Later, please don't do this, not needed. Or you can use a GP, it's called a cone pumping technique. Maybe not bad idea. Cheapest, not bad, but it's comparable. But if you ask me, if you have the money, go for these things. Activator, see the bubbling that happens, much more. Because it goes 2,000, 5,000, 10,000 cycles per minute. Very, very short videos. You can use a brush like Rocco. They have a brush like this that can be used for irrigation. You can use one of my favorites called XP Finisher from FKG, like an umbrella on the tip. So it can go and turn and give the activation that you need to have. It turns and touches, but you have to go up and down so it gets in good contact. This we saw, ultrasonics. And here it is, sorry, this one. Here, this is basically acting on the heat aspect of it. So I'm trying to heat the solution, but see the axis cavity. Caries driven, I didn't take the lingual axis. Proximal caries, from there I went, I have a bendable file. How does it matter? As long as I don't get resistance at the entry point. So what we do is we use a down packed pen to heat the hypochlorite. 180 degrees for about close to a minute. So it gives the bubbling and effervescence and the heat that the hypochlorite needs to work efficiently better. This is lasers. They spoke about lasers. We have the axis of lasers, that's why we are talking about it. But see the debris and all, everything gets cleared. So this is non-contact, you keep it far away and use the laser. It's a hard tissue laser. You get PIPs called photon-induced photoacoustic streaming. The tips are called PIPs, Preciso, X-Pulse, so many things have come, sweeps, plenty of things have come now. You can use one of these irrigation systems. I call it COXO, but it's also from Endovac earlier. Basically, one is negative, one is positive, and there are different needles available for this. So you can use the systems of irrigation. So it's replenishing solution. So use a rubber dam or not, still the solution will not come out of the axis cavity. That's the beauty of the system. If nothing, you know what? Buy a simple micro suction available from Ultradent or Circumed. Put it to a high volume, lock it in your high volume. Tell your assistant to hold it in the canal, and when I'm irrigating here, see what's happening. It's just turning around there. I don't mind now 2 cc, 5 cc, 10 cc, whatever it is, doesn't matter. So that's how it should go. See that? So these are the various suction tips available. Coltin produces some of the good ones, and you can use these tips for microsurgery, as in how you want, from the narrow to the root canal to the surgery to the bigger ones. You can keep on removing them. So these are some of the good tips that you can get. From Circumed you can get this, Ultradent a different tip. So various tips available, you can buy those for your work that you need to do. Right, at the end of it, you know what, this is an extracted tooth sample, it's an ESCM sample, apical sample, this is a laser sample, to be very frank, it's a laser sample. To clean coronal 1/3 is easy, to clean middle 1/3 is also not bad. To get the apical third clean below the curvature is practically impossible. So for which, if you can get such a sample, which is clean, free of bacteria, open, fresh, cut dentinal tubules where your sealer, your molten gutta percha can go and entwine and seal it, that's the best you can achieve, I think. So that's why I think laser was supported. I know the cost factor is very, very high. So second best would be sonics and ultrasonics. So you decide what you want. So the 8th M would be microsurgery. This is one thing that is my passion now. It's very close to my heart now. So we did a microsurgery here. This is not truly a microsurgery. because I didn't use a piezo surgery here. I'm going to show you later. But saw the micro blade, Schwann Morton blade. We used long shank burrs like Lindeman's burr, a bioceramic material that is plugged at the apex, small steps. So again we use Peter Waller's incision. A lot of microsurgery is done at different teeth. Even the premolars and molars are not a problem anymore. Initially we were worried. I used to use a surgeon's help. I still call a surgeon if I want to. So he stands by me and we do it. But today what we do is, this is a guided surgery. If you see this, I can look into my screen and work. It's a dynamic navigation. I've selected my piezo reamer of how much to cut here, 3 millimeters, width and length and all that. And that's exactly what I'm doing there on the screen up there. So as I'm working. So this is called a piezo surgery, called a bone window technique. We remove the bone, do all the procedure and put the bone back. So that's a lid that you're creating on a surgery where there's no bone loss. Precisely you can hit, because when you see there in the screen you saw exactly where we're reaching. So it's another thing. So here are a couple of major, all these surgeries you see, a molar surgery, all are done with the piezos. See that cut that you give, these are molars. But don't start premolars and especially lower molars beginning, please. That's the last thing you will do, not the first thing. Start with upper anteriors. Books said that same. So these are different cases. And bioceramic is the only best material to fill up, please. You have biodentine, you have MTA, you have putties, plenty of things. And for those who don't do much of surgeries, learn suturing, please. There are different sutures, micro and macro. For surgeries today, for endo, we prefer 40 and above, 40, 50, 60, and not silk anymore. They cause a lot of plaque retention. So you have a lot of materials, mono, poly, filaments, plenty of them. So macro is a big one. The needle, the bite is too big. So you're damaging more of it. This is 30. See the difference of how a 5 or 60 looks and how a 30 looks. Next to next also. This is practicing on a model, of course. So here is a case. This is of course my wife, Dr. Rashmi. She's a periodontist. She does this. So see the difference of a perio surgery here. See how a 30 looks, how a 4 and a 5 and a 60 looks. See the healing that takes place. The upper one takes more time to heal because plaque retention, the number of bites. Imagine you're taking so many bites with a 30 and the same thing you're taking a 60. See the difference of the bites and see the way it heals. This I wanted to show because there's so much happening in this area. But in the college, I'm sure still that happens. So the 9th M is about multiple checks. This is exactly what I do in root canal. Checkpoints I must have for every procedure. So that's what I do. Just another 5 to 6 minutes, please. So that's what axis cavity is said. Intracanal medicament coating. Why do I need to see it? I will feel it's brimful. Why? Because on the radiograph if I see, on top it looks filled. See that? Where is the calcium hydroxide at the bottom? Calcium hydroxide works only on contact. So if I want calcium hydroxide deepest layer, I have to break the contact point and the angle. That negative pressure, the C factor is very high in the root canal. So I have to start slowly pumping the material down. It's called cone pumping. So the least I do is this. I do calcium very gently. See what's happening? This is a joining canal. So calcium is moving here. So I am putting the calcium from there to the apex. If I do that, I'm wasting my patient's time and my time. It's not working at all. Why do I put calcium hydroxide? But when you inject or eject, you don't inject, you eject, you deposit. You eject a material, it comes top. I said, okay, full. It looks full there on the radiograph. Nothing is full. Because we don't make a radiograph after calcium hydroxide, it's not needed. For some reason, I made a radiograph and I saw this a few years back. I learned my lesson. I said, no way. Now onwards, I will definitely do some activation. When I put calcium hydroxide, I'll activate to see that it goes to the deepest portion. उसके बाद चाहिए तो और थोड़ा डाल दो या नहीं डाल दो, आपकी इच्छा. Don't push it beyond apex, not needed, because zone of infection is at the apical area. That much if it goes, that's my apical third, that's my middle third, this is my coronal third in the microscope. I can put more or not, choice is yours. Sealer coating. Sealer is a binder. They said AH plus, a good sealer is AH plus. I truly agree, it's true. Not for a down pack technique, but otherwise. Lateral compaction is very popular in the community here. What Stephen Cohen in his book said, you know what? One of the primary requisites of a sealer is to stick like a glue, like a gum, and set like a rock. For that property is no better sealer than a resin sealer. This is the best sealer, but coat it well because it's the binder. Sealer sticks GP to GP, GP to dentine. So see that you coat the canal well all over once nicely. Once that is done, this is my spot check. I'm looking, is it coated? Yes, enough. I don't want flooding, I don't want too much of sealer. I want minimum sealer. And then we have to create lateral compaction. The glorified single cone obturation is all gone. So I wanted to put one addition because cross section of the root canal and the GP point never match. At the apical third, we are trying to match it by preparing the canal with the rotary file. The rotary will prepare the root canal shapes, that whatever shapes they are at the end. They can be teardrop like an eye. When you enlarge it to a certain diameter, then it possibly becomes a circle. Possibly, yeah, not sure. They can still be hideouts. So now when you create a space, you will use a spreader. There's a pointed instrument, a smooth instrument, and deform the master cone. You're deforming you can use a finger or a hand spreader, it's your wish. You deform the master cone and then try and put an additional point on the space that's created because my sealer is less, not flooded. I can see where I want to put. Now see a space again, that space, the dot, again it creates space there. So basically I'm putting a master cone to one side and putting additional cones up to where it goes. That's lateral compaction. Please do this technique at least, please. Now having said what I said, the whole contour is changed. Sealing versus filling. This is the bioceramic sealer. Whether the sealer is thick, it is regenerative, bioactive, all that is true. They flood the sealer with the canal and put single cone. Possibly because retreatment is difficult. I would still say put one additional cone at least to seal it, but here is a single cone. I kept this video for that. So here you see 3 distal canals. See this? Mid distal also is there. See that? Exactly there. They're joining, that's not my problem. And there are 2 mesial canals also joining. When I put the 3 30 size GP points going, and then when I inject, what happens either? And the other canal is coming out. Because they're joining. But this diagnosis you should do before shaping, okay, not now. You will break a file otherwise. Put one canal there, one file there, sorry, in the canal, and another GP point in another canal, and there you get the isthmus and all the fillings. So this is a bioceramic. Here maybe a single cone may work because the sealer is thick. Selective edge technique, of course, yes. Why? When you're having a bioceramic plug, there's a perforation repair I'm doing at the deepest layer. You're not supposed to etch MTA or biodentine. They don't like acids. Like you say, when you put even the foreign speakers who don't believe in calcium hydroxide, when they have to put a bioceramic at the end of the open apex, suppose, or a perforation defect, they will put some calcium hydroxide. Why? To neutralize the defect. That area which is infected should be neutralized. They'll put calcium hydroxide, then they'll wash it off, and the next visit they will put the bioceramic, the plug, the concrete. Their argument is what? I can't remove calcium hydroxide very well from the root canal system, which is true. That's why they prefer 1 visit or 2 visits without a calcium hydroxide. That's why they don't use calcium hydroxide. Then they start arguing it doesn't work with E. faecalis. Fair enough. But there are so many more organisms where calcium hydroxide will work. And if your work is not complete, it will be shorty, use calcium hydroxide. I believe in 2 visits and multiple visits. Then I'd seal it. What we did here, you know what? This is the bioceramic concrete I put in the floor, perforation defect. Somebody referred me the case. I just put a bonding agent on the floor. I closed the floor with the resin composite. And then if you see here, that is my resin composite. I kept a Teflon here. And then I closed the tooth with another restorative and I send the patient back. So if you, sorry, yeah. So if you see this, this is because the doctor wants to earn the money on the core built up. I could have just filled up the whole thing there and completed the procedure. My job was what? Referred case. Just do the perforation sealing. If I don't seal the resin there, when they enter with the burr, they may touch my biodentine or my MTA. Also what I do nowadays is if there are any consultants here, please do that much procedure. If you don't want your root canal to fail, if the other doctor doesn't do a good core built up, at least you are safe. This 2 or 3 millimeters that you are trying to seal is taking care of your root canal. Then they can do what they want here. So I would say any consultant here, just do one layer of core built up, close Teflon, close with Cavit or whatever you want and refer the patient back. So at least you protect your root canals. Seal check. It's not about the post and core I'm showing you this. Seal is the deal. That interface that you want, please use a matrix band and see that you get the best seal possible. Cervical, it's more difficult to get a seal. All of us look at the occlusal surface, doesn't matter for me. What I need to know is cervical which is not seen. Because leakage point is high there. Sulcular fluid, clavicular fluid, gingival fluid, saliva, plus the dentinal tubules are wider and broader there, and they are more in number. All these are your disadvantage. Even it's a vital tooth, class 2 bhi hone do. It's more difficult there. So protect that first when you're doing class 2, rest will happen. Most of us don't take care of there. We do bulk packing there. Not there, sorry. First you should be layering there properly with a flow maybe. Like my favorite is the SDR flow. Then I built up in layers. Then on top anything can happen. So this is one of my most difficult cases which taught me a lot. Dense was the case. Dense type 3. Activation is happening, down pack is happening, empty is happening, backfill is happening. Because 3 canals. It's a type 3 rhomboidal cross section. See the radiograph. 2007 when PG started, this case came to me under microscope. CBCT tha nahi tha bhi. Without CBCT this is. But it taught me a lot of things. So I always show this case whenever I can. Okay. All I'm trying to say is such cases use CBCT compulsorily. Use your consultant or use your seniors help here. Endodontist, they can help you better. Because if I get this case without a microscope, even I will mess it up. So my bioceramic plug is a must for cases like this. See the cross section, it's not circular. If I put GP point, how many GP points? Which is the master point? The master point matlab 1 point. There cannot be 1 point here, multiple points. So you have to use a plug there, a concrete at the apex, then do a backfill or fill any which way. Last M is mastering your skills, which means, see the word, my first 100 teeth for all the young people here. Let it be a filling, let it be a root canal, let it be re-root canal, let it be surgery, let it be anything. Unless you do 100, you have not arrived. I hate when the idea of my PGs or anybody putting second case dalte hai internet, Facebook pe. Why? Because they want a thumbs up. That third case may be equally difficult. So you're not reached there. So don't do that, please. I call it a commander's rule, you know. Commander's rule is what, you know. When a pilot wants to be a commander in flying, there is no vasta, there is no shifaris and all. He has to complete his time, which is called 10,000 flying hours. What is 10,000 flying hours? 6 hours a day, 6 days a week, 25 days a month, 12 months a year, 6 to 8 years if you do the same thing passionately, whatever you love to do. There is no other way except being good. So give that much time, give 8 years, then you will be good. Problem is overnight change nahi milega kuch bhi. Even in dentistry the same story, okay? That's exactly what this means. I want you to elevate your practice, improve your practice. Today if I am standing here, or any one of the speakers speaking here, they've spent that kind of time. They've dedicated their life to this. So it's a labor of love, we say, that's what it is. So start with the extracted tooth first, under loupes or on microscopes, your choice. But step up later and then there's a learning curve. When there's a learning curve, direct vision first and then the indirect vision upper, then the direct vision lower and then the indirect vision lower. Lower comes at last. So here it is. There's a lot of loupes I've used with light, without light, whatever it is. Plenty of loupes I have. And I've used almost all the microscopes that are in India. Because of my travel, because of the workshop that I conduct, because of many other reasons in the colleges also. So if anybody wants to know anything about these things, please ask me. I'll be the right person. With this, I'd like to conclude by thanking each and every one of you. It changed my dental practice. That's exactly what I'm saying. See this? And this is true. For me, it's my life changer, not a game changer. I also teach and train. So this is exactly what we do in our academy, workshops, fellowships and other ways. And I think from Kolkata we've had a lot of participants. And above all, it's the passion, I said, okay? That's exactly what it means. If you want to do anything in life, you have to sacrifice. And that's what it is. With this, I'd like to thank the organizers. Thank you, Chairperson. Thank you for your patient hearing. Thank you.
Thank you, Dr. Hegde. Any questions from audience?
I think I've overshot the lunch time.
Now
Yeah, yeah. You can carry on, carry on.
I would be honored to have our chairperson and felicitate our
Hey, photo. My college needs this. It's all knack and all the things. Thank you so much. Thank you. Thank you. Thank you. Thank you. Thank you. Yeah. Like this, no? Yeah. This is better. Open is it? ये open करना है? आज open करेंगे चलो. आगे. Academics में NAC is asking all these things nowadays. Thank you so much. एक साथ देना ना? हाँ, sure. Thank you.
Now, I will request Professor Dr. Anirban Bhattacharya sir to please come forward and felicitate our chairperson. Now, I will request Dr. Binay Rana, oral and maxillofacial surgeon, who will talk about probiotics and sponsored by JB Chemicals, to please take over the stage.
check, low, low, low. Low, check, low, check. Low, check. Low, 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 low. Low, check, low, low, low. Low, check, low, check. Low, check, low, low. Low, check, 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 low. Check, low, low. Check, low, low. Check, low. Check, low, low. Check.
Did you know that 9 out of 10 Indians suffer from oral problems such as lung, anthracis, gingivitis, periodontitis, and dental caries? But what's the root cause? Oral microflora imbalance, a condition known as oral dysbiosis. To manage oral dysbiosis associated with gingivitis, periodontitis, and dental caries, we are proud to introduce for the first time in India, Sporlac DG, India's first oral dissolving probiotic tablet for oral dysbiosis associated with gingivitis, periodontitis, and dental caries.
Check, low, low.
For the first time in India, Sporlac DG, India's first oral dissolving probiotic tablet for dental health. Each tablet contains
Hello. We are going to start our symposium very soon. Please, everyone be in the auditorium hall. যারা শুনতে চায় তারা এমনি শুনতে পাবে। Symposium maran ki. Symposium maran ki. দের আছে, উই আর প্লুরাল নাম্বার। যবে বলবি তখন থেকে, যখন থেকে বলবি তখন থেকে।
সোমেনদা সোমেনদা টোটাল কটা লাগবে চেয়ার 8টা চেয়ার 1 2 3 4 5 হয়ে গেছে
কেউ হচ্ছে না, এদের তো কেউই নেই। ওটা হলে তো হবে না, এটা স্ক্রিনই প্লে করছে না। প্লে হচ্ছে আর হচ্ছে না, প্লে হচ্ছে তো ডিসপ্লে হচ্ছে না। এটা ভিডিওটা আপনার সেভ আছে? আসছে। সাউন্ডটা আমি ঠিক করে দিচ্ছি, দাঁড়ান আগে স্টার্টিং দিয়ে করে।
কোথায় গেল? বিনয়, এ বিনয়। ইয়ে কাজ করছে না তো, কার্সার কাজ করছে না। হ্যাঁ, করেছে। এই কেউ আছে এখানে? এক্সকিউজ মি, হ্যালো। Somehow it's not working. হ্যাং হয়ে গেছে, দেখ তো। হ্যালো 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 হ্যালো, এটা হ্যালো হ্যালো। হ্যালো। Hello. So we'll be starting our session on Orthopedia Symposium. Moderate. Hey. আজকে মনে হয় বেশি খাবার দাবার আছে, লোকজন খেয়েই যাচ্ছে দেখুন।
হ্যালো।
খেয়েই যাচ্ছে। আজকে প্রচুর খাবার দাবার আছে এক্সট্রা, লোকজন হ্যাঁ ভর্তি তো। খাচ্ছে তো স্যার, কাকে ডাকবো খেতে খেতে। ব্যাস, ইটস শুরু কর। প্লিজ কাম। আরে আমরা আমাদের মতো শুরু করি, তারপরে যারা শুনতে চায় শুনবে, না শুনতে চাইলে না শুনবে। আমি 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 ডেকে নেবো, ওটা আছে নাকি? এ কোথায় গেল? ইয়ে কোথায়?
শুভব্রত শুরু করেন
হ্যালো হ্যালো আমি কি করে আমাকে ইন্ট্রোডিউস করি ও স্যারকে বলি স্যার আপনি একটু তুই
Good afternoon. We have a lot of audience in the post-lunch session.
Hello.
It's time to start because it's already 3:15. So I'd like to call up on stage one by one by our panel experts. First of all, I would like to request Amol Chakraborty sir.
হাততালি
Please. Amitabh sir, please. Rekre sir. আমাদের হাততালিটা জোরে হোক, প্রচুর জোরে হোক। শান্তনু স্যার, প্লিজ on the dais. Shabnam ma'am, and last but not the least, the dynamic Dr. Shomen Pal, who is acting both like a speaker as well as the moderator or everything. Everything has been done by him. And Dr. Shamul Bar. Sir, please. Sir, please. Actually, এত লম্বা লিস্ট চলে আসুন। Let us make it seriously. Let us do it seriously. No doubt.
Arranging it like orthopedo.
Actually, it's a learning session for us also. It's a learning session for us also. And thank you, Professor Dr. Tapan Kumar Giri, Principal R. Ahmed, for being the most serious audience. And he has been waiting there for the last 1 hour for us. A big round of applause for him. So everything is evolving day after day, and dentistry is also a part of this thing. So in this evolving landscape of modern dentistry, we consider dental health as a lifelong continuum rather than discrete or isolated stages. So this was the core concept, the behind thinking for selecting this topic where ortho and pedo merge symbiotically. So why we are calling this symbiotic relationship? Because it is the pediatric dentistry where the early age orthodontics is performed, and this early age orthodontics, it produces a strong biologic foundation for the better adult orthodontic outcome. This early age orthodontics basically includes both preventive and interceptive orthodontics, which either eliminates in some specific cases or it reduces the complexity of adult orthodontic treatment. Conversely, if we think from the orthodontic perspective, adult orthodontic perspective, it also helps to make the pediatric orthodontics more precise, more focused, more simple, and better acceptable for the pediatric population. So both these two wings of dentistry, they are inseparably linked with each other. So our topic, Orthopedo Symposium, there may be some conflicts, and that will be also discussed in today's topic. So first of all, without wasting much time, I would like to ask the first question to Amol Chakraborty sir regarding the basic philosophy of preventive and interceptive orthodontic treatment. And also, I would like to request you, sir, to tell us about how do a clinician differentiate between these two in his day-to-day clinical practice. It's up to you, sir.
Actually, the preventive orthodontics and interceptive orthodontics to some extent overlapping. The preventive orthodontics is only identifying the irregularities in the developing dentition. This is the first thing. And to maintain the integrity of the deciduous dentition is the primary motto of preventive dentistry. Actually, preventive dentistry is not one shot process. It's a long process. Probably it is started from prenatal. So, maternal counseling is important, oral hygiene, genetic aspect of the patient and the family, everything comes in this thing. And nutrition and nutritional status assessment of mother. And this will continue. And exactly if we consider the age of preventive dentistry, we should start watching everything from the eruption of first deciduous tooth to the complete deciduous dentition. This prolonged watching is very important. Every stage, every time we will have to watch everything. So if there is any incipient problem, we should take action about the abnormality, and if we apprehend there is going to be some abnormality in the dentition, then we should intercept. Basically, this process will continue, and preventive dentistry mainly is done without appliance. Basically, without appliance initially, and after that only appliances used for this preventive dentistry is space maintainers and this some mouth guards. So our idea and motto is to maintain the occlusal harmony and smooth switch over from deciduous to permanent dentition without any interferences. This is the basic of preventive. And when comes the interceptive, actually preventive there is no problem. We should be careful and try to find out if there is any potential chance of developing problem in the dentition. But preventive is already some changes has been taken place. There is some abnormality, some deviation, some habits. These things are very important. And in preventive, 3 things should be considered: is arch form, arch constriction, tendency of proclination. These are the important things. Initially, we should look after gradually, continuously. And if there is development of habit, definite arch constriction during the eruption. Actually, most of if we calculate the percentage, 50%, nearly 50% of the malocclusions are class 1 malocclusion. And out of that, 46-7% is crowding. So when the permanent teeth start erupting, we should start watching how many space deficiency is developing, is there with eruption of permanent incisors, upper, lower, like that. If there is development of tendency of development of crowding, then we can go for definite approach to manage the thing. If we find the crowding is going on from anterior arch to middle arch, and space deficiency is not 1, 2, 3 millimeter, it is more than 5, 10 millimeter, then we should consider for definite preventive, interceptive procedure, that is serial extraction. So step by step, according to the clinical feature, changes and habits, what are the effect of habits, we will have to check for. If the patient is continuing thumb sucking, so nature of thumb sucking should be noticed. Whether it is creating any change in the upper arch, lower arch, anterior dentition, you will have to notice. Actually, 3 things should be important: intensity, duration, both the things are important, and frequency. according to modern orthodontic concept, the duration is most important, not the frequency, not the
So in
duration.
case of thumb sucking mainly, sir.
Thumb sucking. So we will have to notice if there is narrowing of the arch, we should intercept. Potential development of crowding, arch constriction and procrastination. These are the main things to be watched. This should be corrected, or we should try to correct first by counseling, parent counseling, counseling of the child, and there are different methods that have been described in literature, Dunlop hypothesis to everything. So if there is definite changes is going on, we should interfere. Otherwise, we should watch and try to control this thing with counseling and all that.
Thank you, sir. Thank you, sir. It was a nice explanation regarding the early age orthodontics. From this point of view or this context, I would like to ask one question to Dr. Shamulbor. Dr. Shamulbor, sir, has been my mentor in Burdwan Dental College regarding orthodontics, because being a periodontist, I used to get so many guidance from Dr. Shamulbor, sir. And during those Burdwan days, we had a small chat regarding the philosophy of serial extraction, sir. Because Amol Chakraborty sir already mentioned the term serial extraction. We have already seen that there are various methods of serial extraction, Duell's method, Nance method, where the erupting premolars are getting extracted. So do we consider serial extraction being a part of interceptive orthodontic treatment or adult orthodontics, because the fours are getting extracted? That's a permanent tooth, not the deciduous one. So in that point of view, if you say something regarding this conflict.
Good afternoon. Thank you for the organizers to make us convey our understanding and our experience to the audience. Mostly we think our discussion should be concentrating on the those who are practicing preventive and interceptive orthodontics, or those who are practicing day-to-day clinic, how the extent they will work on the concept of preventive and interceptives. Your question is that whether there is a specific situations where it is called the serial extractions. Basically, this is a very controversial zone. Because if you are so certain that what will happen, where the tendency of the child are growing towards in maturity, we have to be predicted that with our experience. That means growth factors, growth tendencies, the skeletal, because we are considering a clinical situation at the age of mixed dentitional or early or late mixed dentitional phases. But we have to be taken into considerations what will happen to this particular patients in the adult is an 18 plus. Exactly. So it needs a wide spectrum of knowledge about the growth and development. Most of the cases we teach and we will learn from our clinics or our hospitals that this is the situations you should put this appliance. In our course and curriculums in orthodontia and periodontia, there is some clinical based situations explained to our students.
Hard and fast rule.
There is no analysis. What is the space it will require for this arch to be? Very simple situations. There is a simple single tooth crowding is there. What of this particular individuals? It is a peak of the iceberg. And this particular situation, you ask 100% of the final year students who are sitting in front of us on the opposite side of the table, if we ask what is the cause of these things, they will, and how will solve it, they'll say, I will put a jade spring. And we also in clinics, we go for teach them how to use a pen. So your point of things that particular individuals who are taking a decision that I will extract a permanent teeth that is a fast premolar as in a series of few deciduous and as well as permanent. But what are the space it will be required to correct the situations? If I extract to premolar soil, creating extra nearly about 16 to 70 millimeter space, how does this 16 to 17 millimeter space, whether these developing occlusions will be capable of overcoming, whether there will be an extra space? If there is an extra space, what is the line of treatment? So I think it is in a very premature things for basically for those who are not very widely experienced such type of treatment protocol like what you have asked for, is the serial extraction. I will suggest, sorry, you first know where you are entering. You have to have solutions for extra space as well.
Thank you,
Okay.
sir. You told the same thing during my college days, and I used to follow that. And the next question is for Amitabh sir, and that is, where do periodontists and orthodontists most commonly disagree in timing modality of interceptive treatment? Is there any disagreement? Is there any
Well,
when to start the interceptive?
in the beginning, I must convey my thanks to IDA to honor me to sit at the symposium. Actually, there is no controversy should arise until unless we invite it, because the line of demarcation is very clear. Orthodontist has got no problem with this kind of controversies. Frankly speaking, all controversies come with the periodontist, whether they will go for this much or will not go for this much. I mean, the treatment, interceptive orthodontics. Now, Amal has already told, Dr. Chakraborty has already told about the preventive and interceptive. If you clinically think, interceptive means the problem has already occurred. And if left untreated, it will create a serious problem and will need intense orthodontics. So you have to intercept and restrict it as far as possible. Go to the next. Leave this. Now, in preventive, we are doing something to keep the arch normal. It is otherwise a normal arch. We don't have any problem with the arch, length or arch loss, anything is there, but we have to we have to assume and prevent the loss of arch length. That is the preventive, mainly. Now, go to the next. No, another one. Now, these are the roughly the preventive and interceptive areas we consider. So, some cases, there are controversies, whether we do a periodontist or orthodontist. Like you see one case, space maintenance. Space maintenance is not a malocclusion. Tooth has been extracted. So space maintenance can be done by periodontist. It is a sole area periodontist. Now when they come the space regaining, space is already lost. Now how far a periodontist will act on the treatment of a face regaining? Here it comes. Whether simple 1 or 2 millimeter loss, we can just go for expanding. With the spring you can correct. And when the 7 is already erupted, and only 2 millimeter space is left, still we'll attempt this or send it to orthodontist. This line of demarcation, periodontist have to decide, not orthodontist. So if you know it, if you theoretically you are strong, if you really know the procedure, you can go for a certain limit of orthodontics. But someone told somewhere, if the periodontist works properly, then it's not possible the orthodontist role will be minimized. That is, it's a dream, it's not possible. We can do something beyond our limit. That limit we have to set. There is no controversy in this. I worked 15 years abroad. They follow the American curriculum in Middle East. And practically speaking, there is no controversy. Only space management and just simple as crossbite, early posterior crossbite, which can be expanded by this springs only, by the quad helix. That was our limitations. Anything else, you refer to ortho. There is no chance of doing it. No, you are not allowed to attempt it.
Clear line demarcation.
Clear line demarcation. That is for periodontist.
Thank you, sir. Amitabh sir has told that there is a line of demarcation that has to be determined by the periodontists. Am I audible? No. So there's a clear line of demarcation and that has to be decided by the periodontist. So there may not be any conflict in that case. So we have to decide where to stop, where to do, or where not to do. Now my next question is for Shabnam ma'am. There are few phrases in dentistry that we have came across that has been converted into a proverb. Like during extraction of tooth, we say that chap lagche, betha lagche na. So these things, similarly, whenever a child patient comes up with some malocclusions, in our day-to-day clinical practice as well as in colleges, we used to came across the proverb that let the permanent canine erupt. Let the permanent canine erupt, then only the treatment will be done. So from this context, I would like to ask Shabnam ma'am that at what point does watchful waiting becomes a missed opportunity for early intervention? Should we wait for all the permanent teeth to erupt? Or in case we have to go for early intervention, what are the specific cases where we encounter this?
Before giving the answer, I would like to thank the organizer because most of the time in IDA conference there are very few orthopedo symposium because this interceptive orthodontics, preventive orthodontics, they can't be learned in one courses. So mostly there are no symposium, but we have this and should thank the organizer. And before giving my answer, I would like to contradict Amitabh sir. Amitabh sir told that there is no conflict between ortho and pedo. Of course, in my house there is no conflict because Dr. Ward doesn't have the courage to do anything against me. But in departments, definitely there are conflicts because I remember when I was in as a PG, I'm doing in Aramet Dental College, and we used to put a Howley's appliance, and later on when the patient used to go to the ortho department, the orthodontist used to laugh and they used to tell that you have all the patients you have means পেশেন্টটাকে খারাপ করে পাঠানো হয়েছে এখনও তাই বলা হয় এবং ইন্ডিয়ান অর্থোডন্টিক সোসাইটি দে হ্যাভ ইন দ্য কনস্টিটিউশন দ্যাট ইউ কান্ট টিচ এনিথিং টু এনি পিডোডন্টিস্ট অর এনি ডেন্টাল সার্জন সো নো ওয়ান লার্নস দ্যাট অ্যান্ড ডিউরিং আওয়ার বিডিএস ডেজ we only learn how to observe a patient. We never see a complete case. And even in pedo, our PGs also, in 3 years or 2 years, they are not able to see a complete case. So before coming to my answer, so that's a different thing. But I would like to say that actually when I started my practice, I always thought that after 12 years only I will tell the patient to go for the orthodontic treatment. Because I thought always that my money is my money and my husband's money is my money. So I thought that I will refer all the patient to my husband and he will work and the money I will take it. But later on, eventually, as my PGs, I started learning from him many things. That how to do, because I thought they have to do the procedure. So I learned a lot of things from him and also from my PGs while doing in my patients. And then I suddenly realized that certain cases, like unilateral crossbite, can you show the pictures? Unilateral crossbite cases. So we can start, according to Indian or American Orthodontic Association or American Academy of Pediatric Dentistry, the first screening age for orthodontics is 7 years. But we are so lucky as a pedodontist that, a few months back, a father came to me with a child who is 11 months old with a complaint that the 2 incisor which has erupted, it is proclined. Earlier time, when the person, a lady didn't used to get married at the age of 24 or 25, their parent used to bring the child to the orthodontist. But now the concept has changed a lot. Parents are so much aware about their child's aesthetics. So these type of unilateral crossbite, I will just stand up and I can just, so this is a small case, this is a small child, you can see it's a primary dentition and it's a unilateral crossbite. Many a time we think কিছু করার দরকার নেই, মাত্র 5 বছর বয়স, ও কি কিছু পড়তে পারবে, কিছু করতে পারবে, কিন্তু জাস্ট এই দিস ইউনিল্যাটারাল ক্রসবাইটের জন্য ওর কিন্তু একটা তো টুথ ওয়্যার হতে পারে, টিএম জয়েন্টের ডিস্টারবেন্স হতে পারে, বাইট এ প্রবলেম হতে পারে, ভালো করে চিবিয়েই খাবে না, তার ফলে আজকাল বাচ্চারা এমনিই খেতে চায় না, মা বাবারা টিভি বা মোবাইল দেখতে দেখতে ঘ্যাঁট খাওয়াবে আর আরও চিউ করবে না, তাতে আরও ওদের জ গ্রোথ ইন্টারফেয়ার হবে অ্যান্ড একটা ইউনিল্যাটারাল একটা অ্যাসিমেট্রিক্যাল ফেস ডেভেলপ হয়ে যেতে পারে। কিন্তু আমরা এই কেসটাই একটা জাস্ট একটা আর্চ এক্সপ্যানশন করেছিলাম, আর 3 সপ্তাহের মধ্যে অলমোস্ট আমরা এরকম পেয়েছিলাম 3 সপ্তাহে এরকম মিডলাইন ঠিক হয়েছিল। কিন্তু তারপরে সব থেকে দুঃখের কথা, বাবা বললো যে পুজো আছে, এটা খুলে দিতে হবে, আর বাচ্চা পড়বে না। বাট অ্যাটলিস্ট উই ডিড সার্টেন কেসেস। সো দিস আর দ্য রেড ফ্ল্যাগস দ্যাট উই হ্যাভ টু সি। দেন সার্টেন আর অ্যান্টিরিয়ার ক্রস বাইট, এটা যে কেউ করতে পারে যদি জায়গা আছে। আগে আমরা ভাবতাম অ্যান্টিরিয়ার ক্রস বাইট থাকলেই ঠিক হয়ে যাবে, কিন্তু স্পেস তো থাকতে হবে দাঁতটা এগোবার জন্য। যদি জায়গা থাকে, যে কোনো একটা রিমুভেবল অ্যাপ্লায়েন্স করে আমরা যেগুলো বানাই না, একটা জেড স্প্রিং দিয়ে দিই, সেগুলো দিয়েও আমরা কারেক্ট করতে পারি এগুলো। আরেকটা হচ্ছে স্কেলেটাল ক্লাসটি, খুব বোঝা দরকার কোনটা ডেন্টাল আর কোনটা স্কেলেটাল আর কোনটা ডেন্টোস্কেলেটাল। আমি নিজেই আগে বুঝতাম না, আজকাল একটু বুঝতে শুরু করেছি, মানে 54 বছর বয়স হয়ে গেছে আর প্র্যাকটিস করছি মোর দ্যান 25 ইয়ার্স, এখন একটু বুঝতে শুরু করে। সো ইটস ডিফিকাল্ট টু আন্ডারস্ট্যান্ড। অর্থোডন্টিস্টরা অনেক ভালো বুঝতে পারে, কিন্তু ইউ হ্যাভ টু গো ফর দ্য ওপিজি ল্যাটারাল সেফ দেখে। তো এই ধরনের কেসেসগুলো আর্লি ইন্টারভেনশন খুব দরকার, নাহলে পরে কিন্তু সার্জিক্যাল অর্থোডন্টিক্সে চলে যেতে হবে। তো আমরা এগুলো ওরকম তখন রিভার্স পুল হেডগিয়ার করে আর্চ এক্সপ্যানশন করে কিছুটা হয়তো ঠিক করলাম, তারপরে হয়তো এখানে এস লাইন অনেকটা, তারপরে লেটার অন উই ক্যান সেন্ড ইট দ্য পেশেন্ট টু দ্য অর্থোডন্টিক্স ফর ফার্দার এভ্যালুয়েশন। আর কিছু কিছু কেসে যেমন হচ্ছে যে উঁচু দাঁত আছে, এবং এই ধরনের কেসগুলো কিন্তু দেখা গেছে যে 2 ফেজ ট্রিটমেন্টের থেকে 1 ফেজেও ভালো গেছে, কিন্তু দেখা যাচ্ছে দাঁত প্রচণ্ড উঁচু আছে, এই বাচ্চাগুলো খেলতে খেলতে যখনই পড়বে দাঁত ভেঙে যাবে। সো এটা একটা প্রবলেম। আরেকটা হচ্ছে আমার নিজের দাঁত উঁচু ছিল, আমাকে স্কুলে দেঁতো বলতো, সবাই রাবিট বলতো, আর আমার খুব মনে হতো আমাকে কেউ বোধহয় পছন্দ করবে না। এবং ডক্টর বড় আমাকে যখন পছন্দ করেছে, আমার তখন ব্রেসেস লেগে গেছে আর দাঁতের সেটিং ভালো হয়ে গেছে। নট অনলি দ্যাট, এই যে দাঁত উঁচু থাকার ফলে কনফিডেন্স অলসো গেট হ্যাম্পার, ইয়োর সোশ্যাল অ্যাক্টিভিটি গেট হ্যাম্পার। তো আমার যখন দাঁত নিচু হয়েছিল, তার আগে আমি অঙ্কে 25 পেতাম, 100-তে ফেল করতাম। আমি বলবো না জাস্ট বিকজ অফ দ্য টুথ, বাট আফটার মাই টুথ গেট কারেক্টেড আই বিকেম বেটার ইন মাই স্টাডিজ অলসো। সো এই ধরনের কেসেসগুলো, এছাড়া প্রিম্যাচুর লস অফ প্রাইমারি টুথ, অমিতাভ দাও বললো এরকম, দেখো প্রিম্যাচুর দাঁত তুলে দেওয়া হয়েছে বলে কোনো জায়গাই নেই এখানে, এবং এখানে কিন্তু আমি যদি স্পেস মেনটেন না দিয়ে দিচ্ছি, এত ভালো জায়গা পেয়ে যাচ্ছে। আরেকটা যেটা হয়, পার্মানেন্ট টুথ অ্যাভালশন হয়ে গেছে, সেখানেও কিন্তু আমি কিছু করলাম না, পরে ইমপ্লান্ট লাগাবো 18 বছর বয়সে, বা আমি খোলা পড়ার ডেঞ্চার কিছু দিলাম না, সেখানেও কিন্তু স্পেস লস হতে পারে। আমরা সেখানেও ফিক্স ফাংশনাল স্পেস মেনটেন্যান্স দিয়ে দিই, যাতে 18 বছর বয়সে দে ক্যান গো ফর আ ফিক্সড প্রসেসেস, সেরকম করতে পারি। সো দিজ আর সাম রেড ফ্ল্যাগ। এছাড়া রিটেন ডেসিডুয়াস টুথ, এটা খুব কমন আমরা পাই, এরকম দাঁত ওভার রিটেন deciduous tooth, just because of a retained over retained deciduous tooth কিন্তু এরকম ক্রস বাইট হয়ে যেতে পারে। আর মেয়েটার দেখতে পারো জাস্ট ক্রস বাইটের জন্য ওর কিন্তু ফেশিয়াল অ্যাসিমেট্রি এসে গেছে। খুব সিম্পল জিনিস, একটা ওভার রিটেন deciduous tooth, এবং আমরা ব্যাপারটাকে গুরুত্ব দিই না, পেরেন্টসরা কিন্তু খুব ওয়ারিড হয়, ডাক্তারবাবু এরকম আমার ভেতর থেকে দাঁত এসে গেছে আর আরেকটা দাঁত রয়ে গেছে। তো সিম্পল এক্সট্রাকশন করা খুব দরকার। আরেকটা হচ্ছে যে অনেক সুপার নিউমারারি টিথ থাকে, এই সুপার নিউমারারি টিথগুলো কী করে, ক্রাউডিং করে, পার্মানেন্ট টুথের ইরাপশনকে ইন্টারফেয়ার করে দেয়, অনেক সময় দাঁতটা ভেতরেই আটকে থেকে যায় বা ইররেগুলারিটি হয়ে যায়, ক্রাউডিং হয়ে যায়। সেই জন্য কিন্তু সুপার নিউমারারি টুথ যখনই দেখবো তখন কিন্তু আমরা এরকম তুলে দেবো। তো এরকম একটা কেসেস তুলে আমরা এখানটায় ব্রেসেস দিয়ে করেছি। এছাড়া হচ্ছে ডিফারেন্ট ওরাল হ্যাবিটস, অমল স্যারও বললো, অমিতাভ স্যার বললো, এগুলোও কিন্তু অ্যাজ আর্লি অ্যাজ ডিটেক্টেড। কিন্তু এমন না 3 বছরের বয়সের একটা বাচ্চা আঙুল চুষছে তাকে আমি একটা হ্যাবিট ব্রেকিং, ইটস নট লাইক দ্যাট। সো 4 বছর অবধি কোনো কিছু দেওয়ার দরকারও নেই। আই হ্যাভ কেসেস যেখানে একটা বাচ্চাকে আমি একটা অ্যাপ্লায়েন্স দিয়েছি, মা বাবা পরের দিন এসে হাত জোড় করে বলেছে ডাক্তারবাবু খুলে নিন, পয়সা ফেরত দিতে হবে না। মানে এমন পাগল করে দিয়েছে বাবা মাকে, তাও হয়। সো ইউ হ্যাভ টু আন্ডারস্ট্যান্ড দ্য কমপ্লায়েন্স অফ দ্য চাইল্ড অলসো। তো এগুলো হচ্ছে যেগুলো করতে হবে।
Ma'am, I want to add one question more, that is the face mask therapy regarding, because it's a very difficult for a pediatric patient, a child patient, to wear the face mask. So is there any alternative procedure where the face mask can be avoided for better compliance of the pediatric?
I think for sir, Amol sir bole.
Actually, face mask is used for mid-face depression. Relative class 3. Class 3 may be due to mandibular prognathism or maxillary retrognathism. Maxillary retrognathic underdeveloped. And in this situation, I think the best and probably only solution is face mask. you will have to advance the mandible. You cannot detude the mandible to make the profile straight or better. And mid face is depressed, nasal base is depressed. So you will have to pull the mandible forward. Pull the maxilla forward and to restore the better profile. And most important part of this face mask therapy is ideal age is around 8 years. If you start the treatment at 8 years, you will get the best result. Up to 9 years, result is very good. And from 9 years, the effect start reducing. So better result is expected at this age. There is no delay should be done in this type of cases. Actually, time and tide waits for none, nor does growth spurt. So most important part is the main growth spurt, growth phase is within mainly 11 to 12 years, particularly in girls. Growth is almost completed, and most part of the facial growth is completed by the age of 12 years, when the complete transition of dentition is not even there. So mixed dentition treatment is justified. And not that all patients will come to me, Samuel Bor, Shabnam, or most of the patients will go to the general practitioners. Those who are working, practicing in different, from this point of view, they should learn, understand, and if they can solve the problem, most of the problems will be solved very easily. This should not be required. In the undergraduate syllabus of DCI, these interceptive, preventive, all are taught nicely. If they learn, if they start doing the treatment, if they start understanding, so they can solve many minor problems. In that case, the major complicated malocclusion will not develop in future. And thank you.
Dr. Shamulbor want to add something.
Basically, pedodontists are lucky, and we can say they have a misfortune in both the ways, because most severe and serious malocclusions, which are presented very early phase of life, severe malocclusion, extra teeth, severe proclinations, all sorts of things, first faces by the pedodontist, not the orthodontist. So, what Sir said, Dr. Chakraborty, the general dental surgeons, those who haven't passed out BDS, they are not exposed to all sorts of situations. But our learned pedodontists, they have the exposure of such things, sir. They have to be taken and think about the tip of the iceberg. You don't consider a single teeth malocclusions. You don't consider only a simple habit. You have to be subjected to market risk. You have to assess what are happening in underlying cooking in the oncoming growth. So, and what the last point of discussion was whether any device which has been there for avoid the mid-phase deficiency. That is in a different try had been there, but in my personal practice, I do one thing. It is we don't take usually in face mask we take support from the forehead and the chin. At the same time, what will do, it will prevent the further growth of the mandible and it retract the maxilla. To overcome these compliance and bulkiness and the cumbersome use, there is a method, we used a tandem bow. Tandem bow is a device which is fixed in the maxilla, and one just simple bow-like archware, which is we can fit in the lower molars, and we use the tractions from the upper molar. So it does not require a large frame, and patient can easily dislodge, and he can use throughout the day sometimes. So it has enough, but the success rate is controversial. because there is a large number of cases and meta-analysis is not done. But in my personal practice, I use that.
Both Amol sir and Shamul sir told that general dentists can also practice simple orthodontic treatments. So with this point of view, I would ask Dr. Rekre sir, is there any ethical line where the general dentist can perform orthodontic treatment? If you can enlighten us.
Sure, with your kind permission, moderator sir, can I use the podium?
Definitely.
Yeah, thank you.
Thank you, it's working, sir. It's working, sir.
All right. I was asked a very interesting question about ethics. I seriously feel ethics is very personal. And if you are truthful to yourself, you are doing ethical practice. And if you're not too truthful to yourself, you're not doing ethical practice. Number one. So the question which is being answered by everyone is, should a general dentist do orthodontics? I see a lot of young people sitting here. How many of you would want to do orthodontics or interceptive or preventive orthodontics? Right? You would want to do. So what do you understand by this? Where would you start? Let me tell you where you start. So you have to understand growth. And this is one of the interesting definitions of growth, which I'll read it out for you. I can't see it well over here, so I'll read it from there. Growth was conceived by an anatomist. Yeah, thank you. Born to a biologist, delivered by a physician, left on a chemist's doorstep, adopted by a physiologist. At an early age, she eloped with a statistician, divorced him for a psychologist, and is now being wooed alternatively and concurrently by an endocrinologist, a pediatrician, a physical anthropologist, an educationist, a biochemist, a physicist, a mathematician, and an orthodontist, and the Children's Bureau. So what this essentially means that we are in the gray area of understanding growth. So why do we need to understand growth? We need to at least understand a few concepts of growth. So like Dr. Amal Chakraborty said, pubertal growth, but the ages of puberty are now differing. The age for puberty sometimes in girls is seen to come down to 8 years of age. So even the concepts of pubertal growth spurts. So what do we understand by doing this is the timing of growth. কখন চিকিৎসা করব, কোন বয়সে, কি দেখলে চিকিৎসা করব। So কি দেখতে হবে? Now this is what was the standard procedure which was done, which is now changed. তো এবার আমাকে অন্য কিছু দেখতে হবে, growth evaluation করতে হবে। কিভাবে করব? Do the teeth match with the age of the child? So dental age and chronological age. এক নম্বর কথা। Environmental factors, are they affecting growth? Environmental factors মানে তার মধ্যে, as Dr. Chakraborty said, habits. Can anyone tell me what is a habit? No one? Well, there's a very simple definition. An unconscious repetition of an action is called a habit. So we have to look for habits. What sort of habits? Drinking water is also a habit, but that's not dangerous. So you have to look for habits which are going to cause alteration in the growth pattern or the growth. So the direction of growth, whether you see the patient is tending to develop a prognathic jaw or retrognathic jaw, you have to look for the terminal plane relationships. So this is the way you tend to identify. So you have to keep your eyes open and see specifically. I'll show you a picture. Can you identify this gentleman? That's George Bush, yes. Can you see something in the picture? He's looking at something but not seeing anything. The field glasses have the covers on. So you're looking inside the mouth, but you don't know what to see. So you should see like a single tooth crossbite, as my friend mentioned over here. Well, a single tooth crossbite can be an indication for a developing class 3 situation. So when you find even a single tooth crossbite, please go ahead and do a cephalometric analysis. At the BDS level, we all know how to trace the y-axis. That's very simple. So that is how you can prevent. So yes, interceptive and preventive orthodontics is a great part, the responsibility of a general dental surgeon only. So these are the early signs of the problems. They've all discussed. Thumb sucking. So there is something called thumb or digit sucking or placement of the digit in the mouth. So is the child really sucking the thumb or is only putting the digit in the mouth? Sucking is going to cause a problem. Placing the digit in the mouth, no. But again, for how long? Till what age is the child sucking the thumb? If the child starts sucking the thumb at maybe 6 months of age, in fact, thumb sucking has been noted in intrauterine life also. So till how? Till what time? If the child gives it up before 2.5 years or 3 years or 4 years of age, it's not going to cause any problem. You can just leave the child. So you have to understand how habits work and till what. There's something which we all ignore is mouth breathing. The child has adenoids and it's got mouth breathing. So a simple question, bachcha ki mukh khola rekhe shoye? Ha bollo? Check, send the child to the ENT specialist. He says yes. Well, it's very simple appliance. Put an oral screen, put breathing holes in it, gradually reduce it, and try to revert it to normal oral breathing. So yes, if you know everything, if you're confident you can do this, it is absolutely ethical for any person to practice interceptive or preventive orthodontics.
Thank you, sir. Sir has given us the green signal for the general dentists because they can easily perform. So, sir has told that importance of growth in performing both preventive, interceptive as well as adult orthodontics. So, from this context, I would like to ask Dr. Shomenpal that how much weight should be given to growth prediction and patient compliance while planning interceptive orthodontics. And you can also mention the different investigations, the methods through which the growth prediction can be made.
Now to start with, what is the best outcome that can be having when a treatment has been done for the orthodontic treatment? The four things that matters actually. One is the accurate diagnosis and therapeutic skills of the doctor, patient biological characteristics and patient compliance, and use of different or efficient appropriate orthodontic applies. But the problem is the growth prediction and clinical success, it only depends on the one thing for the patient in a developing time is the patient compliance. If the patient is not compliant with the treatment you are giving, then whatever the treatment, whatever the diagnosis you do, it will have no effect because with the removable appliance. So we have to decide in which case we have to give the removable appliance and which case we have to give for the fixed appliance to change the growth. Because nowadays the orthodontic treatment is for the interceptive part, is not to change the growth but to modulate the growth. You have to modulate the whole growth of the patient and it can do it different appliances from removable to fixed. For me, if you say what is the weightage, how much weight should be given, 60% weight should be given to the orthodontic proper diagnosis for the growth prediction, whereas 40% weight should be given for the patient compliance. Now, how to check the patient compliance? Patient compliance not can be checked easily. Then certain scales are there from where we can check the patient compliance, like attendance at the scheduled appointments, oral hygiene maintenance, proper care of the orthodontic appliance, wearing headgear as prescribed. So if you do that, if you see in the consecutive appointment the patient is wearing or whatever you have been instructed the patient to do and patient is following that, you can say the patient is compliant. Otherwise, what can be happen? You can see a case. So it's March 2024, we have given a appliance for the correction of this crossbite for the face mask therapy. And it's March 2025, after 1 year of treatment, the patient only achieved the H2H occlusion because patient was not wearing it or the properly not following the instruction of the orthodontist or whatever who is doing the treatment at particular for that time. So patient compliance is very important. If the patient is not compliant, if you give a say removable appliance you are giving for the correction of frostbite, patient is not wearing it. So what will happen? It will not achieve any result. For that, for those cases, you have to give fixed appliance. You can go for the 2x4. Or nowadays we are doing what in our
okay, sir, there's other options might be there, like the appliance is not properly working also, but patient compliance is not there, then then sir, it will not work also. In those cases, we can go for the 2x4 appliance, or nowadays we are giving the reciprocal anchorage, only putting two brackets on the tooth in single tooth crossbite and putting the NITA wires. It is correcting almost within 7 days. Or the Catalan appliance, fixed Catalan appliance you can also give. But patient compliance for me is almost having 40% of the weightage, if you give weightage percentage, and 60% is for your growth prediction. This has to be kept in mind.
So I will add another question. Whenever a patient is coming to your clinic and you are watching that the patient is having a maxillary deficiency, right? But should we consider only on the dental arch, or should we investigate for any systemic reason behind the child's growth retardation that can also affect the
Obviously.
dentition?
If
So
the
what are the common investigations that a general dentist should do prior to giving the orthodontic appliances, or is there any importance of the radiograph?
Obviously,
because
there-
we cannot perform this treatment blindly. Most of the cases, what we find that there is a tendency to malpractice, like having a narrow arch, oh, go for a Hydax.
So for that growth prediction,
Expand the arch, but the result is severe relapse or something. It may complicate the treatment is so badly that whenever the patient is going to an orthodontist, he is totally under deep trouble.
so the sole thing we should take care of during planning for this orthodontic treatment for the developing patient is the CVMI stages. We should go for the CVMI stages first, because every cases we have to give the lateral safe. You need to other hand-wrist radiographs to predict your growth. You have a good quality radiograph, that is the lateral safe in your hand. From where seeing the CVMI stages, we can predict, or we can at least select the appliances that has to be given. Like if that was telling, with the face mask therapy or the early arch expansion, it should be given in CVMI stage 1 and 2. But if you want to take the growth parts and you have to change the bony, you have to take bony modulation, that has to be taken place. That like a class 2 DIV1 cases where you have to plan for in twin block appliances. That should be better in case of CBMI stage 3 and 4. So if you have a good quality lateral cephalograph in your hand, you can properly predict the growth, and at the same time, you can get a big chance of having a better result will be there.
Dr. Chomin, you were talking about patient cooperation.
Yes.
Correct. I'll just relate a small story to you. I treated a girl and she used to break her appliance very frequently. When I started teaching her younger sister, I used to ask her, তোমার বোনের ভাঙে না কেন, তোমার কেন ভাঙতো? বলতো স্যার যখন আমার টিউশন যাওয়ার ইচ্ছে থাকতো না আমি নিজে হাতে খুলে ফেলতাম। So patient compliance, she was very compliant, but she had different reasons to break the appliance.
বেসিক্যালি স্যার আমাদের এখানে যেটা হসপিটালে আমরা দেখি যে পেশেন্টকে যখন আমরা যে টাইমে ট্রিটমেন্টটা শুরু করি একটু লোয়ার ক্লাস, হোয়েন এভার দে গো হায়ার আপ ইন দ্য ক্লাস, তাদের পড়াশোনার চাপ বাড়ে এবং দূর থেকে পেশেন্ট আসে, কিছু দিন এসে বলে খুলে দাও, উই ডিডন্ট ওয়ান্ট টু কন্টিনিউ উইথ দিস ট্রিটমেন্ট, হোয়াট এভার দ্য ট্রিটমেন্ট দ্যাট হ্যাজ বিন অ্যাচিভড। আর একটা মজার ব্যাপার হচ্ছে আমি যেটা দেখেছি কমপ্লায়েন্সের ক্ষেত্রে, এদের এক্সপেকটেশন ইজ ভেরি লো। সো লিটল বিট কারেকশন অফ দ্য ম্যালঅক্লুশন, দে আর থিঙ্কিং দ্য ট্রিটমেন্ট ইজ ওভার, সো নিড নট টু গো ফার্দার টু কমপ্লিট দ্য ট্রিটমেন্ট। এটা একটা প্রবলেম হয়ে যায়।
Thank you, Dr. Shumanpal. We also find that the severe maxillary deficiency that can be found in the cleft patients that we encounter. So my next question is for Dr. Shantanu Mukherjee, that what should be the orthodontic treatment approach to a cleft patient if it comes to it?
Actually, treatment of cleft patient is a long continuous journey. It's not a 100-meter sprint, it's a marathon. The treatment starts in infancy. First orthodontic appliance that is given is usually nasoalveolar molding. In many cases, the aim is to reduce the cleft segment, width of the cleft. Although there are some arguments exist against NAM, especially when there is unilateral cleft, width of the cleft is narrow, and moreover it needs increased parental compliance, regular visit to the clinic. These are the disadvantages or arguments against NAM. However, nasoalveolar molding is a common practice, especially in bilateral cleft cases. And in primary dentition, not much orthodontic treatment is done except correction of crossbite Here, main stress is given to maintain meticulous oral hygiene. Oral hygiene reinforcement is our main target. And when patient reaches mixed dentition, in early mixed dentition, maxillary expansion is carried out before placement of alveolar bone graft. And before placement of alveolar bone graft, another orthodontic treatment is required, that is alignment of adjacent teeth adjacent to cleft, mainly the roots of the central incisors which are often inclined. They need to be in upright position. And another thing we should keep in mind that numerous dental defects like missing teeth, supernumerary teeth, rotated teeth, hypodontia, double teeth, enamel hypoplasia, anything may be found in higher incidence compared to normal population. They should be taken into account. After alignment of incisors, bone grafting is done. Bone grafting is one thing is that the chronological, it is not the chronological age which we should follow. We should follow dental age of the patient. When 3/4 to half of canine's root is formed, bone graft should be placed. Why this age is selected? Because it provides integration and maturation, biologic stimulus. Erupting canine provides biologic stimulus to the graft material. That's canine erupts through the graft, right? After placement of graft, when in late mixed dentition, orthodontic treatment is carried out. And when patient reaches permanent dentition stage, comprehensive orthodontic treatment is done. And when he or she reaches adulthood, orthodontic surgery, orthognathic surgery if required is carried out.
Thank you, sir. So you have talked about the maxillary expanders. So my next question is to Dr. Shamulbor about the selection of RMEs and SMEs, rapid maxillary expansion versus slow maxillary expansion. When to do, where to do. So please enlighten us.
Actually, it is I may continue the last questions. Dr. Shantanu has been described nicely. It is in the clay palate is in a situation, is in a mostly neglected in dental perspective, mostly neglected. Even government setups are not up to the infrastructure-wise, not up to the mark to support our rural people. Because in my experience, I have found is in a cleft lip and cleft palate is in a menace of socioeconomic underprivileged. Most of the cleft lip and cleft palate patients are from the below poverty line. And that is why the government college, like our government college, like RMA Dental College, should have an infrastructure for this, the enormous difficulty which the lots of people are facing with the cleft patients. Okay, and you know where it is in a cleft or palate, everything is related to maxilla. That means maxilla is not growing properly. If the maxilla, if I have gradations like that, if the mandible is not number 10, the maxilla will be at the adult life maybe 2, 3, 4, 5. It will never match. So even the most of the cases, the situations like things, the smile pinky and smile trend, all these setups, what will do? He will do only the repair at the age of 18 months, following the rules of 10. But they does not provide any informations to the patients that it needs a continuous process. What Dr. Shantanu has been mentioned. It should be started at birth, and it should be continue up to 18 plus, in the full maturity. So, if there is a maxilla is very small, we have to be mechanically expanded with the help of maxillary expander. So, it should be like this. It is a time-specific procedure. I should not expand a day and 10 millimeters or 17 millimeters or like this. It should be gradual. What Dr. Shantanu has been mentioned, we will put the bone graft. First, we have to be ascertain. We have to be put the bone graft in the first phase to extend the maxilla in the posterior region it is in a good relations with the posterior occlusion first. Show that the transverse relations of the posterior region is become ideal, because maxilla is in sagittally, that means anterior posteriorly, it will be always short. We will solve that problem in later stage. So we should expand the maxilla in a first place in such a way. We should expand so that the posterior region in molar region, the transverse dimensions matched with each other. And after that, we take the graph either from the iliac crest or the ribs to just fill up the gaps. It is in a first phase of bone grafting. Once we put the bone grafting, as Dr. Chakraborty has said, we'll create a space for erupting canine or any residual teeth. Okay, so we'll create a space where should the next series of teeth will come, and at that juncture we have to be considered how much sagittal difficulties are there. If the sagittal difficulties is more than 1.5 to 2 millimeter, 2 centimeter, we should go for the first phase of distraction osteogenesis. We should distract the maxilla in forward directions, at least for try to be. It is not very rarely it happens. We cannot retract the maxilla up to 2 centimeter at a go. So we have to be done in a step way. We may do in a 1.5, maybe 1.8 in maximum. After that, we just wait. Then we align the teeth, rest of the teeth, and we create a situations, wait for the till full complements of the growth. That is in up to 18 years of age, where during this period we try to maintain the mandibular size as much as control as possible. If I find at the end of the day, after 18 years, my maxilla is still short, then I'll return back. It may be we will go for the mandibular setback. We'll go for the mandibular setback, so that the incisor relations can be acceptable facial profile we can get. Okay, from that perspective of view, I have seen many times the maxillary expansion. This is a very beautiful devices. From my experience of around 600 plus cases, I can see that whenever there is a proper understanding that how much space I am going to get by expansions. When there is a borderline cases, we know in general just simple things in every BDS student learn the tooth size, arch size discrepancy. If my discrepancy is within the range of 5 millimeter, if we can easily go for the maxillary expansions. Maxillary expansion with either RME, or rapid maxillary expansions, or slow maxillary expansions. Sorry. My maxillary expansions or mandibular expansions. So I have to be assessed how much expansion and what are the millimeter I can get from an expansion. If it is within the 5 millimeter range, if the maxilla can be expanded properly, at the same time we can align the anterior teeth so that the anterior crowding and sagittal discrepancy we can solve it. Just before that picture, Dr. Shomin has been shown a case over there. There is a picture of a patient, and compliance was the questions from your part. There is a severe crowded case with a maxillary expander. It's a severe maxillary constricted case, high levelly placed, bilateral high levelly placed canines with a severe crowding, and canine does not have any space at all, maybe a 5 millimeter space. We know that those two canines required at least 9 plus 9 at an 18 millimeter of space. So it is definitely there are very good ideas to expand the maxilla, but still there is a requirement of your extractions, because maxillary expansions will provide you maximum 5 to 6 millimeter of space. So you cannot solve the problem with the only simple expansions. So That is why these expanders are, there is different types of expander we use. That is in a bonded or banded. It may be HAS type, it may be Hyrax type, but you have to be taken into the considerations. Where you do in a slow or rapid, basically difference is not the result. Difference is the patient compliance. If you go for the removable one with a slow expander, patient compliance will be always compromised. Always compromised. If you have an want to really expansions, you go for the maxillary expander with the RME, rapid maxillary expander. And what should be your degree of expansion? Your degree of expansions, one turn a day. One turn means 90-degree rotations, and you will get 0.25 millimeter expansions. We can go for a 0.25 millimeter per day, or it may be 0.5 millimeter, 2 turn a day. So we can usually this maxillary expander is available in either 9 millimeter or 11 millimeter or 13 millimeter. So how much expansions we are requiring to level up the posterior sagittal relations, we have to be assessed, and accordingly we can, and considering the patient age, we can turn the expansion. So from 3 weeks to 7 weeks, we can expand our requirements, because we have to be taken into considerations. The most of the cases, maxillary expansions, there's a 40 to 60% relapse is always there. 40 to 60% relapse is always there. So if I expand for a 10, yeah. So many a times we intentionally do the over extensions to cover up the our desired result. Okay. So now the question is that when the situation is very bad, when the maxilla is really constricted, so I need a orthopedic effect, real orthopedic effect. Why we need the maxilla to really bone-based expansions. So we should have to be gone for the surgical assisted orthodontics. What are the question you have placed that when I'll put the canine should be use a canine should be a guideline for the maxillary expansions or orthodontic treatment. You know, there's a 3 teeth, there's a 2 teeth that erupts after full completions of root. We know, everybody. That means the tooth erupts with full completions of the root. That is the canine, maxillary permanent canine, and the third molars, they erupt after full completions of the root. And maxillary incisors, canines, they traverse the maximum distance, and they are the tooth, they erupt at the end of the first series of anterior teeth. Okay, so always their space has been utilized by the premolars and other teeth. So most of the cases, the canines become crowded or high levelly placed. So at that juncture, sometimes we need surgical assisted maxillary expansions. We go for the Sharpe, surgically assisted maxillary expander, or recently introduced in 1997, Marpe, mini implant assisted maxillary expansion. It is no surgical section is required. We put expander with a TAD, 4 TADs, or maybe 2 TADs, and we can successfully produces the orthopedic results with a very good expansions with a scheduled time.
Thank you, sir.
Okay,
Thank you, sir, for giving us the idea about the maxillary expanders. But at one point, I want to contradict you, because being a representative from the government of West Bengal, I must say that in R. Ahmed Dental College and Hospital, the multidisciplinary approaches has been done for over the past few years, and we have been treating the cleft patients with so much success, and the reports has already been submitted to our department. So that's a commendable thing for our government setup. So this thing that I want to add.
Can
And
I
now
make
my
a
next
small
question
observation over here with the permission of the moderator? A small observation. Can I make a small
Yeah,
observation?
sure.
If time permits. Like Dr. Shamal Baur was saying, I belong to Haldia Institute of Dental Sciences, which cannot be considered an urban area. It belongs to the rural area. We get a lot of class 3 and we get a large number of cleft lip and palate patients. And here I would like to share with all of you that for the initial treatment, we have devised and we have actually invented a new appliance where we can reposition the anterior segment. And very recently, we have done a case where we have turned the rapid expander 90 degrees for a sagittal correction, and we split, or we did an osteotomy. I think one of the PG students I saw over here, Neha, you still here? I think you were there in the department when this was done. We turned it round, we created a space for an extra premolar for the anterior posterior discrepancy, and this appliance was entirely designed and created in our department. So, and we put in an extra premolar, and the patient was very happy. We corrected the entire sagittal discrepancy. So, yes, it can be done even in rural areas.
Now you are again going to the basics. My next question is for Dr. Amol Chakraborty sir, that which malocclusions should alert a general dentist to screen for harmful oral habits in children or young adults?
General dental surgeon. I previously also mentioned most of the cases it comes to the general dental surgeon. After that they are referred. Hello? And if they will treat, if they cannot, they will refer to pediodontist or orthodontist, whatever it is. This early treatment, basically the best community service. Community dental treatment they can give, we can give in different parts of the state, district. Not only in Aramed or Holdia Dental College or Guru Nanak Dental College. These are the basic service. Only thing they have to identify, mouth breathing. This is a very common habit. This mouth breathing features you can see. Clinical features will tell you that there is some problem in the facial profile. See the short upper lip, hypotonic upper lip, everted upper lip. This is the interlabial distance, incompetent lip, sometimes associated with increased lower face height. So this should be taken care. Continuous oral habit, like mouth breathing, if continues, there will be different deleterious effects. Not only the dentition, the position, head position, cervical vertebra angulation, everything will be to some extent affected. Now, these are the features. There will be some, due to prolonged mouth breathing, chronic mouth breathing, some gingivitis will appear, redness of the gingiva, erythematous gingiva due to prolonged mouth. So these are the diagnostic features, and treatment should be started for as and when detected. But before that, we dental surgeons can do the use oral screens. But before screening, we should check for the any nasal obstruction or airway obstruction is there or not. So ENT consultation should be done before that, and some tests can be done, butterfly test, water holding test, like that. Now thumb sucking. This is a very common habit. There will be anterior development of anterior open bite, proclination of the upper anteriors, some lingual inclination of lower anteriors, and see the thumb of the patient. There is, for continuous thumb sucking, there will be some keratosis and all that. These are diagnostic features. So again, if thumb sucking is there will be different changes in the oral care, particularly in the maxilla. Upper anterior proclination will be there, but constriction of the upper arch, that is most significant. Bilateral crossbite will start developing. So it should be corrected as early as possible. If even after correction the persistent crossbite is there, we should go for slow maxillary expansion. Not necessarily every time we go for rapid maxillary expansion in growing child, because maxillary sutures are still open and maxillary expansion will give very good result. Next, tongue thrusting. Now this is also a debatable question whether tongue thrusting create the malocclusion or there is that tongue thrusting is secondary. In PG paper today there was discussion about this thing. Tongue thrusting, when basically tongue thrusting is secondary, I think. When there is some open bite, tongue tend to come through the gap, because tongue has a tendency to come between the gum pads from beginning. Anterior closure of in permanent dentition is by closure of lips and forward position of the tongue used to close the gap for suckling and all that. So if there is any gap, tongue will come. Tongue thrusting may be very simple, complex and retain infantile swallowing. So this tongue thrusting should be classified, identified and treated accordingly. Discussion will be prolonged if I discuss the treatment of simple, complex. In complex tongue thrusting, there is complete open bite, anterior, posterior, like that. During swallowing, there will be constriction of the perioral muscle. These are the abnormal things that we can see in with mouth breathing. Again, tongue thrusting, mouth breathing, we can go for this oral screen, or we can give tongue-free, fixed or removable in right time. If the patient cooperation is there, parent cooperation is there, it will be corrected within a very short time. Lip biting, this is also very common. This habit creates proclination of upper anterior and retroinclination of the lower anterior. And along with that, there is some wrinkling in the chin at the time of swallowing, that we call gulp ball chin. This is thrust is given below the upper central incisor. It will tend to procline the upper anterior much more. So this type of lip trap, we can use this lip bumper, simply removable, fixed, for correction of this lip trap. Lip trap should be corrected, because this lip trap, if continues in the long run, it will create definitely a long overjet. So that will be very difficult to correct. So it should be intervened as early as possible. This lip bumper picture is here. Now the functional shift. This is among all these. This functional shift is, I think, the most important and most can have most dangerous consequences if overlooked and not treated properly. Sometimes there is some inclination of one or two central incisor like that, and patient is biting initially edge to edge. Now, due to proper convenience of biting, actually, if they bite on anterior edge to edge, there will be gap on the posterior region. So, for convenience of biting, patient is protruding the lower jaw and getting more better contact on the posterior teeth. So, this will restrict the growth of the upper teeth, forward growth of the maxilla, and the lower jaw will take its own course of growth as usual. So ultimately, if left untreated and growth is completed, a simple pseudoclass 3 malocclusion, this is called pseudoclass 3 malocclusion. This pseudoclass 3 malocclusion will turn into established class 3 malocclusion. The class 3 malocclusion is the most difficult type of malocclusion to correct in orthodontics. So, early action should be taken. Simple bite plane. Only use a bite plane and clear the bite. It will correct gradually. It will allow the maxillary growth, and ultimately it will be corrected. If not, you can use jet spring or some appliances, or 2x4 appliances also can be used with keeping the bite open. Now this is what you said. This class 3 malocclusion I have explained. Anterior crossbite. Again, this is should be corrected as early as possible. Whenever you will get, you just state it.
Thank you,
If
sir.
it is-
Thank you, sir. We have.
No, it is not completed.
Okay, sir.
If the crossbite is there, should be corrected. One tooth, two teeth should be corrected.
As
At
soon as
least
we
if active intervention is not done, keep the bite open. Tongue thrust will gradually, normal tongue thrusting and everything will, oral function will gradually correct the malocclusion. If there is not significant change without active intervention, then we can go for this simple jet spring and all that to correct this. Posterior crossbite. It has been almost explained by Dr. Samuel Ward and all that. When there is posterior crossbite, expand the arch. If within the age limit, we can go for slow expansion. If patient cooperation is not there, go for rapid expansion, but correction should be done. This constricted maxilla is definitely a great problem if not taken care.
Thank you, sir. Thank you, sir. My next question, and probably this will be the last question of this session, that is to Dr. Shabnam Zahir ma'am, that should sleep history and airway assessment be a part of routine mixed dentition evaluation, and how do pedodontists and orthodontists collaborate with ENT specialists and sleep physicians in suspected cases?
Yes, অনেকেরই ঘুম পাচ্ছে তো স্লিপ হিস্ট্রি শুড বি পার্ট অফ আওয়ার অ্যাসেসমেন্ট। তো আমি এখানে একটা বলতে গিয়ে ছোটো করে বলছি, আর টাইম নেই, সেটা হচ্ছে যে আমি নিজে কখনো আগে দেখতাম না, খালি কখন পড়েছি স্যার হ্যাবিট ওসব ওরাল মাউথ ব্রিদিং দেখতাম, বাট ওয়ান্স একটা ইএনটি সার্জন হি সার্চ ফর মি যে পিডোডন্টিস কে আছে, আমি তাকে সব পেশেন্ট রেফার করব বিফোর ডুইং এনি অ্যাডিনোটনসিলেক্টমি টু গেট অ্যান এথিক্যাল ক্লিয়ারেন্স, যেটা করা উচিত। তখন থেকে আমার মনে হলো উনি যখন এতগুলো আমাকে পেশেন্ট রেফার করছে, আমার একটু ভালো করে একটু পড়াশোনা করা দরকার। এবং আরেকটা জিনিস আমি দেখলাম যে যাদের পরের স্লাইডটা দেখাচ্ছি, এই ধরনের বাচ্চা যখন আমাদের কাছে আসে, যে মুখটা এরকম খোলা রয়েছে, ন্যারো এরকম ফেস আছে, আর চোখের তলায় একটা সানকেন অ্যাপিয়ারেন্স আছে, এই রকমের কেস যদি আপনারা কেউ পান, কয়েকটা কোয়েশ্চেন জিজ্ঞেস করতে পারেন। আমরা কখনো জিজ্ঞেসই করি না যে বাচ্চারা কি নাক ডাকে, অনেক ক্ষেত্রে ওরা বলে হ্যাঁ নাক ডাকে। রাতে কি ধরপড় করে উঠে যায়, খুব এদিক ওদিককে মুভ করে, লাতি টাতি মারে, ঘুমানোর সময় বিছানায় হিসি করে, 8 বছরের বাচ্চাকেও জিজ্ঞেস করতে পারেন। এই কোয়েশ্চেন্সগুলো করার পরে যদি আমি মাউথ খুলে দেখি এরকম খুব ন্যারো একটা প্যালেট আছে, ক্রাউডিং আছে, আমাকে আগে থেকেই সাসপেক্ট করতে হবে যে দেয়ার ইজ আ রিস্ক অফ স্লিপ রিলেটেড ব্রিদিং ডিসঅর্ডার্স। কিন্তু উই ডেন্টিস্ট আর নট এবল টু ডায়াগনোজ আ কেস। আমাদের এক্ষেত্রে কিন্তু কেসটা প্রথমে পাঠাতে হবে ইএনটি বা স্লিপ ফিজিশিয়ানদের কাছে, যারা কিন্তু থ্রু পলিসমনোগ্রাফি করে ডিটারমাইন করবে যে ওর অ্যাপনিয়া হাইপাপনিয়া ইন্ডেক্স কত আছে। যদি দেখা যাচ্ছে 15-30 এরকম থাকছে এবং ওদের দেখা যাচ্ছে যে অক্সিজেন স্যাচুরেশন খুব কম আছে, সেক্ষেত্রে তখন ওরা অ্যাডিনোটনসিলেক্টমি, তার সঙ্গে আমরা ডেন্টিস্টরা যেটা করি অসংখ্য মায়োফাংশনাল এক্সারসাইজেস শেখায়, বেলুন ব্লো করা, এরকম সিম্পল এক্সারসাইজে। আরেকটা আমি বলবো, এক্সারসাইজ করতে বললে বাচ্চারা করে না, কেননা পেরেন্টরা আমাদেরকে পে করে না ফর দ্য এক্সারসাইজ, আর্চ এক্সপ্যানশনের জন্য পে করে। সো অলওয়েজ আই রাইট ডাউন ইন দ্য প্রেসক্রিপশন যে এক্সারসাইজের শোন, আর প্রত্যেকবার আসে আমি জিজ্ঞেস করি করে এক্সারসাইজ, এবং সেম টাইম সেম পজিশন সেম লোকেশনে করার। এখন অলরেডি একটা ঘড়ি হয়েছে স্যামসাংয়ে, যেখানে কিন্তু ওরা মেজার করতে পারে কত অক্সিজেন স্যাচুরেশন আছে, ওরা এক্সারসাইজ করছে কিনা। তো এরকম অনেক নতুন ডিভাইসেস হয়েছে, কিন্তু সমস্ত জেনারেল ডেন্টাল সার্জনকে পিডোডন্টি অর্থোডন্টি দে শুড স্ক্রিন, বিকজ আমাদের কাছেই অনেক সময় প্রথমে আসে যে, এবং অ্যাডাল্টসদের ক্ষেত্রে আলাদা, বাচ্চাদের ক্ষেত্রে মোটামুটি অ্যাডিনোটনসিল মানে হাইপারট্রফি ইজ দ্য মেইন রিজন, কিছু ক্ষেত্রে ওবেসিটি, বাট অ্যাডাল্টসদের ক্ষেত্রে কিন্তু ওবেসিটি। আরেকটা স্টাডিতে দেখা গেছে ছোট বাচ্চা যাদের এরকম স্লিপ ডিসঅর্ডার ব্রিদিং আছে, মুখ দিয়ে নিঃশ্বাস নেয়, নাক দিয়ে নেয় না, তাদের ব্লাডে অক্সিজেন কনসেন্ট্রেশন অনেক কম হয়। তার ফলে কী হয়, খুব রেস্টলেস হয়, হাইপার অ্যাক্টিভ হয়, অনেক সময় তাদের দাগিয়ে দেওয়া হয় যে এই খুব অ্যাভারেজ ছেলে, ও পড়াশোনা করে না। আমার ছেলে এরকম খুব সর্দি কাশি ছিল, একদম পড়তো না, অ্যাভারেজই আমরা ভাবতাম। কিন্তু আমার মনে আছে ওর অর্থোডন্টিক ট্রিটমেন্ট হয়েছে, ম্যান্ডিবুলার অ্যাডভান্সমেন্ট হয়েছে, আর প্রত্যেক সপ্তাহে 3 দিন করে খুব লম্বা সন্ডা মতো একজন যোগা টিচার আসতো, যে কিনা ডিপ ব্রিদিং এক্সারসাইজেস শেখাতো। সো অল টুগেদার কম্বাইন ইট বোথ রিট্রেন দ্য মাসলস, রিডাইরেক্ট দ্য জ, যেটা কিন্তু ওর অনেকটা অক্সিজেন স্যাচুরেশন বাড়ায়, তাতে কনসেন্ট্রেশন বাড়ায়, পড়াশোনা বেটার হয়, যে সোশ্যাল পিয়ার রিলেশনস বেটার হয়, তার কনফিডেন্সও বেটার হয়। আর আরেকটা যেটা হয়, যখনই আমাদের অক্সিজেন কনসেন্ট্রেশন কম হয়ে যায়, আমাদের হার্ট বেশি করে কাজ করতে থাকে যাতে ব্লাডে বেশি অক্সিজেন আসে। এই ওভার অ্যাক্টিভিটির জন্য অনেকেরই, যে বাচ্চাদের মাউথ ব্রিদিং আছে বা স্লিপ অ্যাপনিয়া আছে, তারা বড় হয়ে হাইপার টেনশন বা কার্ডিয়াক মায়োপ্যাথি অনেক সময় ডেভেলপ করতে পারে। সেই জন্য ইটস ভেরি ইম্পর্টেন্ট স্ক্রিন করা, তাকে ইন্টারভেন করা। অ্যান্ড আমাদের একটা টিম অ্যাপ্রোচ হওয়া দরকার, অর্থোডন্টিস্ট, ইএনটি অ্যান্ড স্লিপ ফিজিশিয়ান। থ্যাংক ইউ।
Thank you, ma'am. So this is the last question. This is the last question for the session. So I would like the audience, if you have any questions, you can ask. Okay? That will be mentioned by the.
Child tends to breathe from sternum to the mastoid and trapezius more often rather than using diaphragm. So deep breathing helps to diaphragm exercise, diaphragmatic airway exercise, I guess. And second, ma'am, I guess that is what they are saying in posture correction, because our Chakraborty sir bolechen, je forward neck posture. So sometimes they suggest the early children to sit this
Forward and down.
Yes, because sternocleidomastoid constriction, continuously pulling the mandible down, neck posture, cervical chain coming forward. Sometimes standing like this or giving some chiropractic pain helps to correction of the posture, I guess. So this is an, I guess, radiologist can assess.
So this is the point where an oral medicine OMR comes into play. And thank you for your valuable inputs. Thank you very much.
One thing I'd like to mention is the tongue position. Tongue position, if tongue is raised, there will be more abduction. If tongue is posteriorly placed, this is very common in class 2 malocclusion. In class 2 malocclusion cases, should be observed from very early stage. And if there is mandible is short, and class 2 is due to short mandible, not due to propline upper jaw. The tongue along with the lower jaw will be posteriorly placed and little high up. In that case, there will be more tendency of, this is the first concern of the dental surgeon and orthodontist, to bring the mandible forward with myofunctional appliance This is the most important thing that we can do to get better airway for forward position of the tongue along with the mandible. Next, the airway and all that should be checked. If there is deviated nasal septum, the adenoids you mentioned, these are the what we can do, that is forward positioning of the mandible. It increases the airway definitely.
I just make one observation over here. We can measure the upper and lower airway and the composite airway on lateral cephalograms. We have done it in our department. We have quantified airway, and we have related it to the type of malocclusion which develops. We have related it with the shape of the condylar fossa, and we have found definite differences. And we have also worked with the orthopedic department of our college, surgical orthopedic department, and we have correlated with the spinal position, spinal curvature, and the malocclusion. So it's all been done in our department. You can have come, the dissertations have been done on it. So you're most welcome to my college and my department to have a look at it.
Thank you, sir. Thank you, ma'am.
Just a minute. Hello.
Thank you everyone for patient hearing. So the session ends. Thank you.
It was a wonderful session of our Ortho-Pedo Symposium. Thank you to the speakers. I request Dr. Subrata Pal to please felicitate our speakers. Dr. Amol Kumar Chakraborty. Dr. Shantanu Mukherjee. Dr. Shabnam Zahir. Dr. Shomen Pal. Dr. Amitava Chakraborty. Dr. R.D. Rekade. Dr. Shamal Bor. And last but not the least, the moderator of the session, Dr. Shubhabrata Pal.
এই কাগজগুলো নামিয়ে দাও, এটা ক্লিন করে দাও। যাতে আমি করতে পারি লিখ। চাটা সব খাওয়া দাওয়া আছে, আপনার তো মিটিং আছে, আপনি কোথায় গেছেন? এটা নিয়ে নাও, এটা নিয়ে নাও, জল দিয়ে দেয়। রেকর্ডিং আর লাগবে না, রেকর্ডিং কজন বাজবে এখানে? না রেকর্ডিং বন্ধ থাকলে ইউটিউব কি করছো? রেকর্ডিং বন্ধ থাকছে, তাহলে ইউটিউব তুমি কি করছো? ভিডিও বন্ধ টেবিল একটা এই চা রেডি তো না না শুধু তোমার হ্যালো ভাই কোথায় গেলি ওখানে রেখে দে এই দাও স্যার ওই কোনায় গেছে তাকে দেখা যাবে তাহলে চা রেডি তো চা চা দিয়ে দিবি না কিছু চা দিয়ে দিবি চা